Cardiovascular System Audiobook for USMLE Step 1. Now listen carefully, because this is where it all begins. Embryology, heart morphogenesis. The heart is actually the first functional organ in vertebrate embryos, and it begins to beat spontaneously by week 4 of development. Isn't that fascinating? Then comes cardiac looping, where the primary heart tube loops, and this crucial process helps establish left-right polarity, and again, this begins in week 4 of development. But here's something you should remember: if there's a defect in left-right dynein, which is involved in left-right asymmetry, it can actually lead to dextrocardia, and this is seen in Cardigener syndrome. Now let's talk about septation of the chambers, especially the atria, where the septum primum grows toward the endocardial cushions, which narrows the ostium primum, and while that's happening, the ostium secundum forms in the septum primum due to cell death, which causes the ostium primum to regress. Meanwhile, the septum secundum begins to develop on the right side of the septum primum, and as the ostium secundum maintains the right-to-left shunt, the septum secundum expands and covers most of the ostium secundum. The residual foramen here is called the foramen ovale, and the remaining portion of the septum primum forms the one-way valve of the foramen ovale. So here's what happens next: the septum primum closes against the septum secundum, and this seals the foramen ovale soon after birth, all because of increased left atrial pressure and decreased right atrial pressure. Are you following me? Good, because in infancy or early childhood, the septum secundum and septum primum fuse completely, forming what we call the atrial septum. But when that fusion fails, we get a condition called patent foramen ovale. This is a failure of the septum primum and septum secundum to fuse after birth, and it's seen in about 25% of the population, though most of these individuals are asymptomatic and their condition remains undetected. However, you should remember this: it can lead to paradoxical emboli, meaning venous thromboembolus may enter the systemic arterial circulation through a right-to-left shunt, just like an atrial septal defect or ASD. Now let's move on and explore the ventricles, where the muscular interventricular septum forms first, and there's an opening called the interventricular foramen. Then, the aorticopulmonary septum rotates and fuses with the muscular ventricular septum, and this forms the membranous interventricular septum, effectively closing that foramen. Meanwhile, growth of the endocardial cushions plays a big role by separating the atria from the ventricles, and they also contribute to both atrial septation and the membranous portion of the interventricular septum. Are you ready for an important fact? Ventricular septal defect is actually the most common congenital cardiac anomaly, and it usually occurs in the membranous septum. Now listen carefully, because here's something even more intricate: atrioventricular septal defect, or AVSD, is also known as an endocardial cushion defect or AV canal defect. It's an acyanotic congenital heart defect that features a single common AV valve, along with either ASD alone, which is called partial AVSD, or both ASD and VSD, known as complete AVSD. This defect is associated with conditions like Down syndrome, and it's also linked to maternal diabetes and obesity, so it's essential to understand how these associations can impact development. Now we turn our attention to the outflow tract formation, where neural crest cell migrations create the truncal and bulbar ridges, and these ridges spiral and fuse to form the aorticopulmonary septum, which then gives rise to the ascending aorta and the pulmonary trunk. But you should remember this: conotruncal abnormalities can happen if neural crest cells fail to migrate, and this leads to conditions such as transposition of the great arteries or TGA, tetralogy of Fallot, and persistent truncus arteriosus, all of which are significant congenital heart defects. Finally, let's talk about valve development, where the aortic and pulmonary valves are derived from the endocardial cushions of the outflow tract, and the mitral and tricuspid valves are formed from the fused endocardial cushions of the AV canal. But things can go wrong here too. Valvular anomalies may present as stenotic, regurgitant, atretic, for example in tricuspid atresia, or even displaced, such as in the case of Epstein anomaly. So, keep this all in mind: from the earliest beat of the heart to the final shape of its valves, every step is finely tuned, and any misstep can have lifelong consequences. Now let's dive into the beautiful transformation of the heart during embryology, and are you ready? Because each structure in the embryo gives rise to something truly essential in the mature heart. The right common cardinal vein and the right anterior cardinal vein together give rise to the superior vena cava, also known as the SVC, while the posterior cardinal veins, the subcardinal veins, and the supracardinal veins all come together to form the inferior vena cava, or IVC, and this is an important distinction to remember. Next, the right horn of the sinus venosus contributes to the smooth part of the right atrium, which is also called the sinus venerum, while the left horn of the sinus venosus becomes the coronary sinus, and this helps drain blood from the heart's own circulation. Now listen carefully, because the primitive pulmonary vein forms the smooth part of the left atrium, while the primitive atrium itself turns into the trabeculated part of both the left and right atria, and that's a beautiful example of symmetry in development. But wait, there's more, because the endocardial cushion gives rise to the atrial septum, and also to the membranous interventricular septum, and even to the atrioventricular and semilunar valves. Are you following me? Good, because the primitive ventricle becomes the trabeculated part of both the left and right ventricles, while the bulbous cordus gives rise to the smooth parts, yes, the outflow tracts, of the left and right ventricles. And finally, the truncus arteriosus develops into both the ascending aorta and the pulmonary trunk, completing this stunning transformation from primitive tissue to complex cardiovascular anatomy. Now let's shift gears and talk about fetal to postnatal changes, because you should remember, these transitions are vital. The ductus arteriosus, which connects the pulmonary artery to the aorta in the fetus, closes after birth and becomes the ligamentum arteriosum, and this is located near the left recurrent laryngeal nerve. Then we have the ductus venosus, which shunts blood away from the liver in the fetus, and this becomes the ligamentum venosum after birth. Now listen carefully, because the foramen ovale, that little flap that lets blood flow from the right atrium to the left atrium before birth, becomes the fossa ovalis after closure. The allantois, through a structure known as the urachus, turns into the median umbilical ligament, and remember this, the urachus is a fibrous remnant that connects the bladder to the umbilicus. Also, the umbilical arteries, which once carried deoxygenated blood from the fetus back to the placenta, become the medial umbilical ligaments, and the umbilical vein, which once brought oxygenated blood into the fetal body, transforms into the ligamentum teres hepatis, also called the round ligament, and it is contained within the falciform ligament of the liver. So, from veins and valves to arteries and atria, these embryonic structures shape the foundations of life, and understanding their transformations helps us appreciate the heart not just as a pump, but as a masterpiece of developmental biology. Now listen carefully, because fetal circulation is truly a masterpiece of physiological design, and there are three important shunts that make it all possible. First, the umbilical vein carries richly oxygenated blood from the placenta, and it flows into the ductus venosus, which then enters the inferior vena cava, and this clever pathway bypasses the hepatic circulation, allowing more efficient delivery of oxygenated blood to the heart. Next, most of this highly oxygenated blood coming from the inferior vena cava enters the right atrium, but instead of going to the lungs, it passes through the foramen ovale, and from there directly into the left atrium. This right-to-left shunt helps ensure that oxygen-rich blood reaches the brain and upper body. But that's not all, because the deoxygenated blood, mostly coming from the superior vena cava, goes into the right atrium, then into the right ventricle, and from there it enters the main pulmonary artery. Now here's the twist, instead of going to the lungs, which have very high resistance in the fetus, this blood is shunted through the ductus arteriosus and into the descending aorta. This brilliant detour happens because of high fetal pulmonary artery resistance, and it helps the fetus send most of the blood flow to the rest of the body instead of the non-functioning fetal lungs. Are you following me? Good, because now comes the most dramatic shift. At birth, the infant takes a breath, and this reduces resistance in the pulmonary vasculature, which leads to increased left atrial pressure compared to the right atrial pressure, and that causes the foramen ovale to close. This spot is now called the fossa ovalis. At the same time, the increase in oxygen from respiration, along with a decrease in prostaglandins due to placental separation, causes the ductus arteriosus to close, transforming it into the ligamentum arteriosum. Now listen carefully, because there's a powerful pharmacological trick here. NSAIDs, like indomethacin or ibuprofen, and even acetaminophen, can help close a patent ductus arteriosus, often abbreviated as PDA, and when that happens, the ductus arteriosus becomes the ligamentum arteriosum. Just remember this cool phrase, endomethacin ends the PDA. On the flip side, prostaglandins E1 and E2 are known to keep the PDA open, which can be useful in certain congenital heart defects where mixing of blood is temporarily life-saving. So let's bring it all together: the pulmonary artery, the superior vena cava, the foramen ovale, and the ductus arteriosus all undergo incredible changes. The ductus arteriosus becomes the ligamentum arteriosum, the ductus venosus becomes the ligamentum venosum, and the umbilical vein transforms into the ligamentum teres, which is nestled within the falciform ligament of the liver. The umbilical arteries also undergo change, they become the medial umbilical ligaments. And running through all of this is the incredible transition from fetal to postnatal life. Now let's talk about heart anatomy, which reveals some fascinating spatial relationships. The left atrium, abbreviated as LA, is the most posterior part of the heart, and this is important clinically, because LA enlargement, as seen in conditions like mitral stenosis, can lead to some unexpected consequences. For instance, the enlarged LA can compress the esophagus, and that may result in dysphagia, or difficulty swallowing. But that's not all, it can also compress the left recurrent laryngeal nerve, which is a branch of the vagus nerve, and this compression may lead to hoarseness, a condition known as Ortner syndrome. Now moving forward, the right ventricle, or RV, is the most anterior part of the heart, and because of its location, it is also the most commonly injured during blunt chest trauma. When we look at the heart's inferior or diaphragmatic surface, the left ventricle, or LV, makes up about 2/3, while the right ventricle contributes around 1/3, a detail that's easy to overlook but clinically relevant. Are you following me? Because now we're diving into the layers of the pericardium, which is the protective sac surrounding the heart. It consists of 3 layers, arranged from outermost to innermost: the fibrous pericardium, the parietal pericardium, and the epicardium, which is also known as the visceral pericardium. Between the parietal layer and the epicardium lies the pericardial space, and this is where pericardial fluid resides, allowing smooth movement of the heart as it beats. The pericardium is innervated by the phrenic nerve, and this connection explains why pericarditis, inflammation of the pericardium, can cause referred pain to the neck, the arms, or even one or both shoulders, and more often than not, it's the left shoulder that's affected. You should remember this, because pericardial pain can mimic other conditions, making diagnosis tricky if the anatomy isn't well understood. Now listen carefully as we explore the coronary blood supply, which is vital to keeping the heart itself alive. The left anterior descending artery, commonly called LAD, and its branches supply the anterior 2/3 of the interventricular septum, the anterolateral papillary muscle, and the anterior surface of the left ventricle. It's important to note that this artery is the most commonly occluded in myocardial infarctions. The posterior descending artery, or PDA, is another major player. It supplies the posterior 1/3 of the interventricular septum, the posterior 2/3 of the ventricular walls, the posteromedial papillary muscle, and even the sinoatrial and atrioventricular nodes, depending on coronary dominance. When infarcted, it may cause nodal dysfunction, resulting in bradycardia or even heart block. The right, or acute, marginal artery supplies the right ventricle, a function that's often overlooked. Are you ready for a deeper dive? Because coronary dominance plays a key role in determining which artery supplies the PDA. In a right dominant circulation, which is the most common type, the PDA arises from the right coronary artery. In a left dominant circulation, found in about 5 to 10% of people, the PDA arises from the left circumflex artery. And then we have the codominant circulation, present in about 10 to 20% of individuals, where the PDA receives contributions from both the LCX and the RCA. Another interesting point, coronary blood flow to the left ventricle and the interventricular septum peaks during early diastole, which is quite different from most other tissues, where perfusion occurs mostly during systole. And don't forget, the coronary sinus runs in the left atrioventricular groove and drains directly into the right atrium. Cardiovascular physiology. Now let's start with cardiac output variables, starting with stroke volume, which is the amount of blood ejected by the ventricle during each heartbeat. Stroke volume is influenced by three major factors: contractility, afterload, and preload. Stroke volume increases with increased contractility, such as what happens during anxiety or exercise, and it also increases with increased preload, as seen in early pregnancy. On the other hand, stroke volume decreases when afterload rises. So remember this helpful acronym, SVCAP, which stands for stroke volume is affected by contractility, afterload, and preload. Now listen carefully, because stroke work, abbreviated as SW, represents the work done by the ventricle to eject the stroke volume, and it is proportional to stroke volume multiplied by mean arterial pressure. In short, SW is directly proportional to SV times MAP. In cases of heart failure, stroke volume decreases due to systolic or diastolic dysfunction. Are you following me? Because now we're moving to contractility, which refers to the strength of the heart's contraction. Contractility, and therefore stroke volume, increases with catecholamine stimulation through the beta-1 receptor. This leads to activation of protein kinase A, which phosphorylates phospholambin, causing more calcium to be stored in the sarcoplasmic reticulum. Also, protein kinase A phosphorylates calcium channels, which allows more calcium to enter the cell, promoting calcium-induced calcium release. These mechanisms all contribute to increased intracellular calcium. Another way to increase contractility is through digoxin, which blocks the sodium-potassium pump, leading to increased intracellular sodium, which then reduces the activity of the sodium-calcium exchanger, and the result is more intracellular calcium. But remember this, contractility and stroke volume decrease with beta-1 blockade, which reduces CMP, and they also fall in heart failure with systolic dysfunction, during acidosis, in low oxygen or high carbon dioxide states, and when non-dihydropyridine calcium channel blockers are used. Now let's discuss preload, which is approximated by ventricular end-diastolic volume, or EDV. Preload depends on venous tone and circulating blood volume, both of which determine venous return. When venous return is high, preload increases. Venous vasodilators, like nitroglycerin, reduce preload by decreasing venous tone, so less blood returns to the heart. This reduction in preload can ease the workload of the heart, especially in conditions with volume overload. So, preload is not just a number, it reflects how much the heart is stretched before it contracts. Next, are you ready to explore cardiac oxygen demand? Because myocardial oxygen demand increases when contractility rises, and it also increases with higher afterload, which is directly proportional to arterial pressure. A faster heart rate also raises oxygen demand, and so does a larger ventricular diameter, since wall tension increases. You should remember this, the coronary sinus contains the most deoxygenated blood in the entire body, highlighting how much oxygen the myocardium consumes. According to Laplace's law, wall tension equals pressure times radius, and wall stress equals pressure times radius divided by 2 times wall thickness. So, as wall tension increases, myocardial oxygen demand goes up significantly. Now listen carefully as we finish with afterload, which is approximated by mean arterial pressure, or MAP. When pressure increases, wall tension rises, and this increases afterload. The left ventricle compensates for high afterload by undergoing hypertrophy, which is a thickening of the ventricular wall, in order to reduce wall stress. Arterial vasodilators like hydralazine decrease afterload, while ACE inhibitors and ARBs reduce both preload and afterload. In chronic hypertension, where MAP remains elevated, the result is left ventricular hypertrophy, a key adaptive response that can have long-term consequences. Now let's talk about resistance, pressure, and flow, which are central to understanding cardiovascular dynamics. First, remember that volumetric flow rate, often represented as Q, equals flow velocity, or V, multiplied by cross-sectional area, or A. That means Q equals V times A. Now listen carefully, because resistance, abbreviated as R, is defined as the driving pressure, or delta P, divided by flow. But more specifically, resistance equals 8 times viscosity, written as eta, multiplied by the length of the vessel, all divided by pi times the radius to the 4th power. In other words, R equals 8 eta L over pi r to the fourth. This shows that resistance is inversely proportional to the fourth power of the radius, so a small change in radius leads to a large change in resistance. Are you following me? Because total resistance behaves differently depending on whether vessels are in series or in parallel. When blood vessels are arranged in series, the total resistance, labeled RT, is simply the sum of individual resistances. That means RT equals R1 plus R2 plus R3, and so on. But when vessels are in parallel, the total resistance is calculated differently. The reciprocal of total resistance equals the sum of the reciprocals of the individual resistances. So, 1 over RT equals 1 over R1 plus 1 over R2 plus 1 over R3, and so on. Now here's something important. The equation delta P equals Q times R is analogous to Ohm's law in electricity, where voltage equals current times resistance. And don't forget, resistance is proportional to 1 over the radius to the fourth power, so again, R is proportional to 1 over R to the fourth. Now let's shift to flow characteristics. Capillaries have the highest total cross-sectional area of all vessels, and as a result, they have the lowest flow velocity. Pressure gradients are what drive flow. Blood always moves from regions of high pressure to regions of low pressure. Arterioles contribute most to total peripheral resistance, or TPR, and veins are responsible for most of the body's blood storage capacity. Now listen carefully, because viscosity, which affects resistance, depends mostly on hematocrit. It increases in hyperproteinemic states such as multiple myeloma and in polycythemia, while it decreases in anemia. Are you ready? Because now we move on to cardiac and vascular function curves, which illustrate the relationship between cardiac output, venous return, and right atrial pressure. When you look at the graphs, the intersection point between the cardiac output curve and the vascular function curve is called the operating point of the heart, and this represents the balance where venous return equals cardiac output, since the circulatory system is a closed loop. Now let's talk about what shifts these curves. First is inotropy, or the contractile strength of the heart. Changes in inotropy alter stroke volume, and that affects both cardiac output and right atrial pressure. For example, catecholamines, dobutamine, digoxin, and exercise increase inotropy. That's a positive effect. In contrast, heart failure with reduced ejection fraction, narcotic overdose, and sympathetic inhibition reduce inotropy. That's a negative effect. Next is venous return. Changes in circulating blood volume or venous tone affect right atrial pressure and stroke volume, and therefore change cardiac output. Examples of increased venous return include fluid infusion, sympathetic nervous system activation, and arteriovenous shunts. Decreased venous return can occur in acute hemorrhage or spinal anesthesia. Finally, we look at total peripheral resistance. Changes in TPR directly affect cardiac output. However, changes in right atrial pressure are less predictable. For instance, vasopressors increase TPR, while exercise and arteriovenous shunts decrease it. You should remember this: these changes often occur together, and they may be reinforcing, such as during exercise when inotropy increases and TPR decreases to maximize cardiac output. But they can also be compensatory, as seen in heart failure, where decreased inotropy leads to fluid retention and increased preload, all aimed at maintaining cardiac output. Now let's talk about resistance, pressure, and flow, which are central to understanding cardiovascular dynamics. First, remember that volumetric flow rate, often represented as Q, equals flow velocity, or V, multiplied by cross-sectional area, or A. That means Q equals V times A. Now listen carefully, because resistance, abbreviated as R, is defined as the driving pressure, or delta P, divided by flow. But more specifically, resistance equals 8 times viscosity, written as eta, multiplied by the length of the vessel, all divided by pi times the radius to the fourth power. In other words, R equals 8 eta L over pi r to the fourth. This shows that resistance is inversely proportional to the fourth power of the radius, so a small change in radius leads to a large change in resistance. Are you following me? Because total resistance behaves differently depending on whether vessels are in series or in parallel. When blood vessels are arranged in series, the total resistance, labeled RT, is simply the sum of individual resistances. That means RT equals R1 plus R2 plus R3, and so on. But when vessels are in parallel, the total resistance is calculated differently. The reciprocal of total resistance equals the sum of the reciprocals of the individual resistances. So, 1 over RT equals 1 over R1 plus 1 over R2 plus 1 over R3, and so on. Now here's something important. The equation delta P equals Q times R is analogous to Ohm's law in electricity, where voltage equals current times resistance. And don't forget, resistance is proportional to 1 over the radius to the fourth power, so again, R is proportional to 1 over R to the fourth. Now let's shift to flow characteristics. Capillaries have the highest total cross-sectional area of all vessels, and as a result, they have the lowest flow velocity. Pressure gradients are what drive flow. Blood always moves from regions of high pressure to regions of low pressure. Arterioles contribute most to total peripheral resistance, or TPR, and veins are responsible for most of the body's blood storage capacity. Now listen carefully, because viscosity, which affects resistance, depends mostly on hematocrit. It increases in hyperproteinemic states such as multiple myeloma and in polycythemia, while it decreases in anemia. Are you ready? Because now we move on to cardiac and vascular function curves, which illustrate the relationship between cardiac output, venous return, and right atrial pressure. When you look at the graphs, the intersection point between the cardiac output curve and the vascular function curve is called the operating point of the heart, and this represents the balance where venous return equals cardiac output, since the circulatory system is a closed loop. Now let's talk about what shifts these curves. First is inotropy, or the contractile strength of the heart. Changes in inotropy alter stroke volume, and that affects both cardiac output and right atrial pressure. For example, catecholamines, dobutamine, digoxin, and exercise increase inotropy. That's a positive effect. In contrast, heart failure with reduced ejection fraction, narcotic overdose, and sympathetic inhibition reduce inotropy. That's a negative effect. Next is venous return. Changes in circulating blood volume or venous tone affect right atrial pressure and stroke volume, and therefore change cardiac output. Examples of increased venous return include fluid infusion, sympathetic nervous system activation, and arteriovenous shunts. Decreased venous return can occur in acute hemorrhage or spinal anesthesia. Finally, we look at total peripheral resistance. Changes in TPR directly affect cardiac output. However, changes in right atrial pressure are less predictable. For instance, vasopressors increase TPR, while exercise and arteriovenous shunts decrease it. You should remember this: these changes often occur together, and they may be reinforcing, such as during exercise when inotropy increases and TPR decreases to maximize cardiac output. But they can also be compensatory, as seen in heart failure, where decreased inotropy leads to fluid retention and increased preload, all aimed at maintaining cardiac output. Now let's talk about the pressure-volume loops and the cardiac cycle. This section focuses on how pressure and volume change throughout the cardiac cycle, especially in the left ventricle. We'll walk through each phase in sequence and explain the associated heart sounds, pressure curves, and ECG components, so listen carefully. The black loop you see in the diagram represents normal cardiac physiology. Starting with the phases of the left ventricle, we begin at isovolumetric contraction, which is the period between the closing of the mitral valve and the opening of the aortic valve. This phase is where the heart consumes the highest amount of oxygen. Next comes systolic ejection, which is the time between the opening and closing of the aortic valve. After that, we enter isovolumetric relaxation, which begins as the aortic valve closes and ends when the mitral valve opens. Following this, we move into rapid filling, which occurs just after the mitral valve opens, and then comes reduced filling, the phase just before the mitral valve closes again. Now listen carefully as we go over the heart sounds, labeled S1 through S4. S1 corresponds to the closure of the mitral and tricuspid valves and is loudest at the mitral area. S2 is the sound of the aortic and pulmonary valves closing and is best heard at the left upper sternal border. S3 occurs in early diastole, during the rapid ventricular filling phase, and is best heard at the apex, especially when the patient is in the left lateral decubitus position. This sound is associated with increased filling pressures, such as in mitral regurgitation, aortic regurgitation, heart failure, and thyrotoxicosis. It's also more common in dilated ventricles, though it can be normal in children, young adults, athletes, and even during pregnancy. It results from turbulence as blood from the left atrium mixes with a high end systolic volume. S4, on the other hand, occurs in late diastole during the atrial kick, and the sound is due to blood entering a stiffened left ventricle. This is also best heard at the apex with the patient in the left lateral decubitus position, and it reflects high atrial pressure. It is associated with ventricular noncompliance, such as in hypertrophy, and it is considered abnormal if it's palpable. S4 is common in older adults. Now let's switch to the jugular venous pulse, or JVP, which reflects pressure changes in the right atrium. The A wave corresponds to atrial contraction, and it's prominent in atrioventricular dissociation, seen as cannon A waves, and also in elevated right ventricular end diastolic pressure from various causes. The A wave is absent in atrial fibrillation. The C wave results from right ventricular contraction, causing the closed tricuspid valve to bulge into the right atrium. The X descent follows, representing atrial relaxation and the downward displacement of the closed tricuspid valve during the rapid ejection phase of the ventricle. The X descent is reduced or absent in tricuspid regurgitation and right-sided heart failure, because the pressure gradients are diminished. The V wave reflects increased right atrial pressure due to the accumulation of blood against a closed tricuspid valve. Finally, the Y descent marks the emptying of the right atrium into the right ventricle. This descent is prominent in constrictive pericarditis but absent in cardiac tamponade. Now, as for the pressure volume loop itself, keep in mind that stroke volume is defined as end diastolic volume minus end systolic volume, or SV equals EDV minus ESV. The key valve events are shown along the edges of the loop. The mitral valve closes, the aortic valve opens, then the aortic valve closes, and finally the mitral valve opens again. The width of the loop equals stroke volume, and the end systolic volume shifts left or right depending on contractility. Increased afterload, such as in aortic stenosis, makes the loop taller and narrower, while increased preload, such as in increased venous return, expands the loop to the right, increasing stroke volume. Increased contractility shifts the end systolic point leftward, increasing both stroke volume and ejection fraction. Lastly, looking at the cardiac cycle across time, with corresponding ECG components, the P wave indicates atrial depolarization, the QRS complex marks ventricular depolarization and contraction, and the T wave represents ventricular repolarization. Aortic pressure rises and falls during systole and diastole, and the dicrotic notch represents aortic valve closure. During this cycle, ventricular volume and left atrial pressure rise and fall in synchrony with the valve events and heart sounds, including S1, S2, S3, and S4. Now let's talk about jugular venous pressure tracings, which can provide valuable clues about cardiac conditions. In a normal JVP tracing, we see the classic sequence of waves and descents, starting with the A wave, followed by the C wave, then the X descent, the V wave, and finally the Y descent. This smooth pattern reflects normal right atrial pressure changes during the cardiac cycle. However, in atrial fibrillation, the A waves are absent. That's because the atria aren't contracting effectively, and as a result, there's no atrial kick to generate the A wave. You should remember this pattern when evaluating irregular rhythms. Next, in tricuspid regurgitation, the X descent is absent. This happens because the backflow of blood into the right atrium during systole reduces the normal downward movement of pressure. Instead, you might see a combined CV wave due to regurgitant flow. In constrictive pericarditis, the tracing shows a prominent Y descent, which reflects rapid early diastolic filling into a non-compliant ventricle, followed by a sudden halt. The Y descent becomes sharp and deep, making it a key diagnostic clue. Meanwhile, in cardiac tamponade, the Y descent is absent, because the accumulation of pericardial fluid restricts the ability of the right atrium to empty into the right ventricle. This leads to a blunted or flat Y wave and should raise suspicion for tamponade physiology. Now listen carefully as we shift to pressure-volume loops in valvular disease, starting with aortic stenosis. In this condition, the left ventricular pressure increases significantly, and this pressure becomes much higher than the aortic pressure during systole. The end-systolic volume increases, and although the end-diastolic volume may stay unchanged in mild cases, the stroke volume decreases. Over time, the ventricle compensates by undergoing hypertrophy, which reduces ventricular compliance and increases end-diastolic pressure for any given volume. Next, let's explore aortic regurgitation. In this condition, there is no true isovolumetric phase, because the aortic valve fails to close completely. This results in increased end-diastolic volume, a higher stroke volume, and a wide pulse pressure. You'll also see a loss of the dicrotic notch, which normally indicates the closure of the aortic valve. These features are classic for chronic aortic regurgitation. Now we turn to mitral stenosis, where the left atrial pressure exceeds the left ventricular pressure during diastole. This leads to elevated left atrial pressure, reduced end-diastolic volume, reduced end-systolic volume, and ultimately a decrease in stroke volume due to impaired ventricular filling. This pattern is especially important in rheumatic heart disease. Let's now consider mitral regurgitation. In this condition, there is no true isovolumetric phase, just like in aortic regurgitation. During systole, blood flows backward into the left atrium, reducing resistance and lowering end-systolic volume. At the same time, the left atrium receives extra volume, leading to increased end-diastolic volume in the left ventricle. As a result, stroke volume increases, but that increase includes both forward flow into the systemic circulation and backflow into the left atrium. One key feature in the JVP is a tall V wave, caused by the increased left atrial pressure during systole. Now listen carefully as we discuss the splitting of the second heart sound, commonly known as S2. The most familiar form is called physiologic splitting, which occurs during inspiration. When you inhale, the intrathoracic pressure drops, and this drop leads to increased venous return, which means more blood flows into the right ventricle. That increase in filling causes the right ventricle stroke volume to rise, and as a result, the right ventricle takes longer to eject blood, so the pulmonic valve closes later than usual. Also, remember that pulmonary impedance decreases during inspiration, which means the pulmonary circulation has more capacity, further contributing to the delay in pulmonic valve closure. So during inspiration, what you hear is a normal delay between aortic valve closure, A2, and pulmonic valve closure, P2. That's the sound of physiologic splitting, and it's expected. During expiration, the sounds are closer together, but during inspiration, A2 comes first, then P2. Now let's talk about wide splitting. This happens in conditions that cause a delay in right ventricular emptying, such as pulmonic stenosis or a right bundle branch block. Because the right ventricle takes longer to push blood through the narrowed or delayed pathway, the pulmonic valve closes even later, especially on inspiration. This creates a wider than normal gap between A2 and P2. So, wide splitting is simply an exaggeration of physiologic splitting, and it's pathologic. Next comes fixed splitting, and you should remember this pattern carefully. It's most commonly heard in atrial septal defect, or ASD. In ASD, there is a left-to-right shunt, which increases the right atrial and right ventricular volumes, and this increases the flow through the pulmonic valve, causing it to close later. But here's the key detail: this delay in P2 does not vary with respiration, so the split remains fixed during both inspiration and expiration. Now let's look at something called paradoxical splitting. This occurs when the aortic valve is delayed, such as in aortic stenosis or a left bundle branch block. In paradoxical splitting, the usual order of closure is reversed. Instead of A2 followed by P2, now P2 comes before A2. And here's why it's called paradoxical: during inspiration, the delayed A2 moves closer to the now later P2, and this eliminates the split that should have become more noticeable. Then, during expiration, the split reappears, which is the opposite of what happens in physiologic splitting. Now listen carefully as we begin auscultation of the heart. When we listen to heart sounds, we focus on four main areas: the aortic area, the pulmonic area, the tricuspid area, and the mitral area, also called the apex. And to help remember their locations, just think of the acronym APTM, standing for aortic, pulmonic, tricuspid, and mitral. First, let's start with the aortic area, which is located at the right upper sternal border. Here, you'll hear systolic murmurs, especially from aortic stenosis, flow murmurs like those seen in high-output states or fever, and aortic valve sclerosis. Next, move to the pulmonic area, at the left upper sternal border. Here, you also hear systolic murmurs, including those from pulmonic stenosis, atrial septal defect, and flow murmurs, just like in the aortic area. Now let's talk about the tricuspid area, which lies along the lower left sternal border. In this area, you may hear holosystolic murmurs, such as tricuspid regurgitation and ventricular septal defect. You can also hear diastolic murmurs, like those caused by tricuspid stenosis. Then we come to the mitral area, also known as the apex of the heart, which is located at the fifth intercostal space at the midclavicular line. In this region, you'll hear systolic murmurs from mitral regurgitation and mitral valve prolapse, and diastolic murmurs caused by mitral stenosis. Now let's not forget the left sternal border, where we often detect murmurs from hypertrophic cardiomyopathy during systole, and aortic regurgitation or pulmonic regurgitation during diastole. Are you following me? Good, because now we move on to how maneuvers affect heart murmurs. Let's go through this step by step. When a patient stands up or performs the Valsalva maneuver during its strain phase, there's a decrease in preload, meaning the left ventricle fills with less blood. This leads to an earlier midsystolic click in mitral valve prolapse, and it intensifies the murmur of hypertrophic cardiomyopathy. However, most other murmurs, like those from stenosis or regurgitation, decrease in intensity, because of reduced flow. Now, if you do a passive leg raise, that increases preload, meaning more blood fills the heart. This enhances most murmurs, due to the greater flow across faulty valves, but it delays the midsystolic click in mitral valve prolapse, and it softens the murmur in hypertrophic cardiomyopathy. Next, squatting increases both preload and afterload, leading to more left ventricular volume. As a result, most murmurs get louder, except the murmur of hypertrophic cardiomyopathy, which softens due to the increased volume, and the murmur of mitral valve prolapse, which gets a later click. Let's keep going. During the hand grip maneuver, afterload increases significantly. This results in increased reverse flow across the aortic valve. So, murmurs from aortic regurgitation, mitral regurgitation, and ventricular septal defect get louder. However, the murmur of aortic stenosis gets softer, and the murmur of hypertrophic cardiomyopathy also decreases, due to the increased volume in the left ventricle. Now pay attention to the effects of respiration. When you inhale, venous return to the right heart increases, but venous return to the left heart decreases. This means right-sided murmurs get louder with inspiration, while left-sided murmurs increase with expiration. Now listen carefully, because we're going to talk about systolic murmurs, and first up is aortic stenosis. This murmur has a crescendo-decrescendo ejection quality, meaning it builds up and then fades, and it's loudest at the heart base, radiating up to the carotids. You might notice a soft second heart sound, sometimes accompanied by an ejection click. Clinically, you'll observe what's called pulsus parvus et tardus, which means the patient has weak pulses with a delayed peak. This condition is often age-related, due to calcification of the aortic valve in people older than 60. But in some cases, it happens earlier, especially in those with a bicuspid aortic valve, usually starting around age 50 or 60. And remember, it can lead to serious symptoms like syncope, angina, and dyspnea on exertion. So you should always think of LV pressure exceeding aortic pressure during systole as the key hemodynamic change here. Now let's talk about mitral and tricuspid regurgitation, both of which produce a holosystolic, high-pitched blowing murmur. In mitral regurgitation, the murmur is loudest at the apex and radiates toward the axilla, while in tricuspid regurgitation, it's loudest at the tricuspid area. Mitral regurgitation may be caused by ischemic heart disease, especially after a myocardial infarction, or due to mitral valve prolapse, left ventricular dilation, or rheumatic fever. On the other hand, tricuspid regurgitation is usually caused by right ventricular dilation, and sometimes it's due to pacemaker lead injury. Both murmurs may also be caused by infective endocarditis, particularly in 4-drug users. So whenever you hear this kind of murmur, think about these underlying structural or infectious causes. Are you following me? Because now we're moving on to mitral valve prolapse, which produces a late crescendo systolic murmur that's best known for its mid-systolic click. This click usually occurs after the carotid pulse and is heard best over the apex, with the murmur getting louder just before the second heart sound. Most of the time, this condition is benign, but in some cases, it can predispose a person to infective endocarditis. It may result from rheumatic fever, rupture of the chordae tendineae, mitral annular disjunction, or myxomatous degeneration, which could be either primary or secondary to connective tissue diseases like Marfan or Ehlers-Danlos. That click you hear is from the sudden tensing of the chordae tendineae, as the mitral leaflets bulge into the left atrium, and this tension gives rise to the crescendo murmur with a click. Now let's move on to ventricular septal defect, or VSD, which also gives a holosystolic murmur, but this one has a harsh sound. It's usually loudest at the tricuspid area, and it's a hallmark of congenital heart disease. Interestingly, the size of the defect affects the intensity. Larger VSDs actually produce softer murmurs compared to smaller ones, because there's less turbulence due to lower pressure gradients. So when you hear a harsh murmur in this location, especially in a child, you should always consider VSD, and remember that softer doesn't always mean milder. Now let's talk about diastolic murmurs, starting with aortic regurgitation, which produces an early diastolic, decrescendo, high-pitched blowing murmur. It's best heard at the heart base if it's due to aortic root dilation, or along the left sternal border if it's a valvular problem. The common causes can be remembered by the mnemonic BEAR, bicuspid aortic valve, endocarditis, aortic root dilation, and rheumatic fever. Clinically, you'll observe a wide pulse pressure, a pistol shot sound in the femoral artery, and sometimes even pulsing nail beds or head bobbing if the regurgitation is severe and chronic. Over time, this condition may progress to left heart failure, so it's important to catch and monitor it early. Next, let's cover mitral stenosis, which creates a murmur that follows an opening snap. This murmur is delayed, rumbling, and occurs in mid to late diastole. The key here is that the shorter the interval between S2 and the opening snap, the more severe the stenosis. It's a late and highly specific complication of rheumatic fever, and in chronic cases, it leads to left atrial dilation, pulmonary congestion, and atrial fibrillation. You might also see Ortner syndrome, where the recurrent laryngeal nerve is compressed by an enlarged left atrium, leading to hoarseness, and in some cases, even hemoptysis and right heart failure. The snap you hear is caused by the sudden halt in motion of the mitral valve leaflets, which have fused at the tips, and this results in LA pressure being much higher than LV pressure during diastole. Finally, let's talk about a continuous murmur caused by patent ductus arteriosus, or PDA. This murmur is machine-like, continuous throughout systole and diastole, and it's best heard at the left infraclavicular area, loudest around S2. It's often due to congenital rubella infection or prematurity, especially in infants where the ductus fails to close after birth. A helpful way to remember it is, you need a patent for that machine. Just like a machine running non-stop, this murmur doesn't take a break, and its continuous nature makes it stand out during auscultation. Now listen carefully, we're going to explore the myocardial action potential, which occurs in all cardiac myocytes except those in the SA and AV nodes. This process unfolds in 5 distinct phases. Phase 0 is known as the rapid upstroke and depolarization phase. During this phase, the fast voltage-gated sodium channels open, allowing a sudden influx of Na+ ions, which quickly depolarizes the myocyte membrane. Following that, we have phase 1, the initial repolarization, marked by the inactivation of those same sodium channels. Simultaneously, transient outward potassium channels begin to open, which causes a brief but important drop in voltage. Now let's talk about phase 2, often remembered as the plateau phase or sometimes nicknamed plateau. This phase is unique to cardiac myocytes because it features a balance. Calcium ions enter the cell through voltage-gated calcium channels, while potassium ions exit the cell. This balance creates a flat, sustained plateau. The calcium influx is not just for voltage, it also triggers calcium release from the sarcoplasmic reticulum, leading directly to myocyte contraction. This is what we call excitation-contraction coupling, a key difference from skeletal muscle physiology. Are you following me? Good, because next comes phase 3, which is the phase of rapid repolarization. This happens because potassium ions flow out of the cell, specifically through slow-delayed rectifier K+ channels. At the same time, the voltage-gated calcium channels close, tipping the balance and allowing the cell to return to its resting state. Finally, we arrive at phase 4, the resting potential. During this phase, the cell maintains its resting state through high potassium permeability, allowing potassium ions to exit through specialized K+ channels, keeping the inside of the cell negatively charged and stable until the next depolarization. Now let's highlight the differences between cardiac muscle and skeletal muscle. Cardiac muscle has a plateau phase in its action potential, due to the balance between calcium influx and potassium efflux. Contraction in cardiac muscle requires calcium influx from the extracellular fluid, which then stimulates additional calcium release from the sarcoplasmic reticulum. This process is called calcium-induced calcium release. Another unique trait is that cardiac myocytes conduct excitation throughout the heart via specialized connections known as gap junctions, ensuring coordinated contraction. Now listen carefully, because we're switching to the pacemaker action potential, which occurs in the SA and AV nodes, and has a very different pattern. In these cells, phase 4 is a slow, spontaneous diastolic depolarization, driven by what's called the funny current, abbreviated as if. This current flows through HCN channels, which allow a mixed inward flow of Na+ and K+ ions, slowly bringing the membrane potential toward the threshold. This automatic depolarization is what gives the SA and AV nodes their pacemaking ability. You should remember this, the slope of phase 4 in the SA node determines the heart rate. If you increase this slope, the heart rate increases. Agents like acetylcholine and adenosine slow this depolarization and decrease the heart rate, while catecholamine speed it up and increase the heart rate. Sympathetic stimulation increases the likelihood that HCN channels are open, which makes the heart beat faster. Next comes phase 0, the upstroke, but here, it's caused by the opening of voltage-gated calcium channels, not sodium channels. This is because in pacemaker cells, the resting potential is less negative, so fast voltage-gated sodium channels stay inactivated, resulting in slow conduction velocity, which is useful at the AV node to delay ventricular contraction. Now let's wrap it up with phase 3, the repolarization phase in pacemaker cells. It occurs when the calcium channels inactivate and potassium channels open, allowing potassium ions to leave the cell, which brings the membrane potential back down. Remember, phases 1 and 2 are absent in pacemaker cells, and that's another key difference from ventricular myocytes. All of this creates a cycle of spontaneous depolarization and repolarization that keeps your heart beating rhythmically. Now let's talk about the conduction pathway of the heart, which begins at the sinoatrial node, commonly called the SA node. This tiny but powerful structure is located in the upper portion of the crista terminalis, near the opening of the superior vena cava. It serves as the dominant pacemaker of the heart, setting the rhythm by initiating impulses with a slow phase of upstroke. From the SA node, the electrical signal spreads across the atria, causing atrial depolarization, and then travels to the atrioventricular node, or AV node, which is located in the interatrial septum, near the coronary sinus opening. Importantly, this AV node introduces a 100 millisecond delay, giving the ventricles enough time to fill before they contract. Are you following me? Good, because after the AV node, the impulse moves into the bundle of his, and from there, it branches into the right bundle branch and the left bundle branch. The left bundle branch splits further into two smaller pathways, the left anterior fascicle and the left posterior fascicle. These branches carry the signal down to the Purkinje fibers, which rapidly spread the impulse throughout the ventricles, allowing for a powerful and coordinated contraction. So, the full order is SA node, atria, AV node, bundle of his, right and left bundle branches, and finally, the Purkinje fibers. That's the entire conduction sequence of the heartbeat. Now listen carefully, because we're going to compare two important rhythms, pacemaker rates and conduction speeds. The pacemaker rates follow this order: the SA node fires fastest, followed by the atria, then the AV node, and finally the bundle of his, Purkinje fibers, and ventricles. Meanwhile, the speed of conduction is highest in the his Purkinje system, followed by the atria, then the ventricles, and slowest in the AV node. A handy mnemonic is, he parks at Ventura Avenue, which helps you recall the order of conduction speed: his Purkinje, atria, ventricles, AV node. Now let's break down the components of the ECG. The P wave represents atrial depolarization, that's when the atria contract. The PR interval measures the time from the beginning of atrial depolarization to the beginning of ventricular depolarization, and this normally lasts between 120 and 200 milliseconds. The next big feature is the QRS complex, which reflects ventricular depolarization, and it should be 100 milliseconds or less in a healthy heart. The QT interval covers the entire duration of ventricular depolarization, contraction, and repolarization. After that, we see the T wave, which represents ventricular repolarization, and if the T wave is inverted, it could be a sign of ischemia or a recent myocardial infarction. Are you ready to learn more? Then focus on the J point, which marks the transition between the end of the QRS complex and the start of the ST segment. The ST segment itself is normally flat, or isoelectric, because the ventricles are fully depolarized during this time. Finally, we have the U wave, which is not always visible, but when it is prominent, it may indicate hypokalemia, or bradycardia. A fun way to remember this is to think of hypokalemia as hip, U, kalemia, linking the U wave to low potassium levels. Now you should picture the anatomical layout, starting again at the SA node, and tracing the path through the Bachmann bundle, the AV node, the bundle of his, then to the right and left bundle branches, and into the Purkinje fibers. Along the way, don't forget the left anterior and posterior fascicles, which help distribute the impulse across the left ventricle. Now let's talk about atrial natriuretic peptide, or ANP, which is released from atrial myocytes in response to increased blood volume and higher atrial pressure. This hormone acts through cyclic GMP, also known as cGMP, and causes vasodilation, while also reducing sodium reabsorption at the renal collecting tubule. It has additional effects: it dilates the afferent arterioles of the kidney and constricts the efferent arterioles, which promotes diuresis, helping the body eliminate excess fluid. This action also contributes to what's called the aldosterone escape mechanism, a protective process that prevents excessive salt and water retention, even when aldosterone is elevated. Now listen carefully, another important molecule is B-type natriuretic peptide, often called BNP. This one is released from ventricular myocytes in response to increased wall tension, and it has similar physiological actions to ANP, but with a longer half-life, which makes it more stable in the bloodstream. Because of that, BNP blood tests are especially useful in diagnosing heart failure, and they have a very good negative predictive value, meaning that a normal BNP level strongly suggests heart failure is not present. You should remember this: the baroreceptors and chemoreceptors in the body play critical roles in maintaining cardiovascular stability. These sensors send signals to the medulla, particularly the cardiovascular center, through various nerves. Inside the medulla, key nuclei such as the dorsal motor nucleus of the vagus, the nucleus ambiguus, and the nucleus tractus solitarius process these signals. From there, messages are transmitted to structures like the SA node and AV node, or through the sympathetic chain ganglion, depending on whether the signal is parasympathetic or sympathetic. Now let's talk about the baroreceptors. The aortic arch baroreceptors transmit signals via the vagus nerve, also known as cranial nerve X, to the nucleus tractus solitarius in the medulla, and they respond to changes in blood pressure. Meanwhile, the carotid sinus, which is the dilated region just above the bifurcation of the carotid arteries, sends signals via the glossopharyngeal nerve, or cranial nerve 9, also to the nucleus tractus solitarius. This region too responds to changes in blood pressure. These afferent signals are then processed, and appropriate autonomic responses are initiated. Are you following me? Good, because now we shift to the chemoreceptors. Peripheral chemoreceptors, located in the carotid and aortic bodies, are activated by increased carbon dioxide levels, decreased blood pH, and oxygen levels less than 60 mm of mercury. On the other hand, central chemoreceptors, found in the brain, are stimulated by changes in pH and carbon dioxide levels in the brain interstitial fluid. However, they are influenced indirectly by arterial carbon dioxide, because hydrogen ions cannot cross the blood-brain barrier. Interestingly, central chemoreceptors do not respond to oxygen levels, and over time, especially in chronic conditions like COPD, they become less sensitive to carbon dioxide. This makes the body more reliant on peripheral chemoreceptors to detect low oxygen and drive respiration. Now listen carefully to how baroreceptors respond to hypotension. When arterial pressure drops, there is less stretch on the baroreceptors, which leads to reduced afferent firing. This reduction signals the nervous system to increase sympathetic output and decrease parasympathetic stimulation, resulting in vasoconstriction, a faster heart rate, increased contractility, and ultimately, a rise in blood pressure. This mechanism is critical during hypovolemic shock. Now let's talk about carotid sinus hypersensitivity, which can be triggered by carotid massage, shaving, or wearing a tight shirt collar. These actions increase pressure on the carotid sinus, leading to increased afferent baroreceptor firing, which prolongs the AV node refractory period, slows the heart rate, and decreases cardiac output. It also causes peripheral vasodilation, which can result in presyncope or syncope. This condition is more common in people with underlying atherosclerosis, those who have had neck surgery, and older adults. You should remember this. Baroreceptors are also involved in a special condition called the Cushing reflex, which is a triad consisting of hypertension, bradycardia, and respiratory depression. It occurs when intracranial pressure increases, causing arteriolar constriction in the brain. This leads to cerebral ischemia, which results in elevated carbon dioxide and decreased pH. In response, the central sympathetic reflex attempts to raise perfusion pressure through hypertension, which then increases stretch at the baroreceptors, triggering a peripheral reflex that results in bradycardia. Do you know shit about normal resting cardiac pressures? One of the key measurements here is the pulmonary capillary wedge pressure, also known as PCWP, and it is measured in millimeters of mercury. This pressure is a good approximation of left atrial pressure, but you should remember that it becomes inaccurate in mitral stenosis, where the PCWP becomes higher than the left ventricular end diastolic pressure. This discrepancy is important clinically. The PCWP is typically measured using a pulmonary artery catheter, often referred to as a Swan-Ganz catheter. Listen carefully now, because knowing the typical pressure values across the heart and circulation helps you assess hemodynamics. The PCWP is normally less than 12 mm of mercury. The right atrial pressure is usually less than 5, and the right ventricular pressure ranges from 4 to 25 in diastolic and systolic respectively. The pulmonary artery pressure ranges from 8 to 25, and left ventricular pressure can go from 12 to 120 in diastolic and systolic. The aortic pressure, which reflects systemic arterial pressure, typically ranges from 80 to 120 mm of mercury in diastolic and systolic respectively. Are you following me? Good, because now we shift to the topic of autoregulation, which refers to how blood flow to an organ stays constant, even when the perfusion pressure changes over a wide range. Each organ has its own unique mechanisms to achieve this. Let's begin with the lungs, and they behave differently from most other organs. In the pulmonary circulation, hypoxia causes vasoconstriction, which may seem counterintuitive at first. But the reason is clear: the lungs direct blood away from poorly ventilated areas and send it to better oxygenated regions. So, only well-ventilated areas are perfused effectively. You should remember this contrast because in other organs, hypoxia actually causes vasodilation, not vasoconstriction. In the heart, the local vasodilators include nitric oxide, carbon dioxide, and decreased oxygen. In the brain, blood flow vasodilation is regulated mostly by carbon dioxide levels, which affect the pH of the interstitial fluid. When it comes to the kidneys, two important mechanisms are at play: the myogenic response, which is a stretch-dependent reaction of the afferent arteriole, and tubuloglomerular feedback, which adjusts flow based on signals from the distal tubule. Let's not forget the skeletal muscle. During exercise, blood flow increases due to several local vasodilatory metabolites, including carbon dioxide, hydrogen ions, adenosine, lactate, and potassium ions. However, at rest, skeletal muscle blood flow is mostly controlled by sympathetic tone in the arteries. Finally, the skin is a special case. Its blood flow is regulated primarily by sympathetic vasoconstriction, which is crucial for maintaining body temperature. Now let's talk about capillary fluid exchange, because understanding this helps explain how fluid moves in and out of our blood vessels. Starling forces determine fluid movement through capillary walls, and you should remember this: Pc, which is capillary hydrostatic pressure, pushes fluid out of the capillary, while Pi, which is interstitial hydrostatic pressure, pushes fluid into the capillary. Then there's Pi-C, or plasma oncotic pressure, which pulls fluid into the capillary, and finally Pi-I, or interstitial fluid oncotic pressure, which pulls fluid out of the capillary. Are you following me? Great, because here's the formula you need to keep in mind: JV, which is the net fluid flow, equals Kf times the quantity of Pc minus Pi, minus sigma times the quantity of Pi-C minus Pi-I. Let's break that down. Kf stands for capillary permeability to fluid, and sigma, or the reflection coefficient, is a measure of how impermeable the capillary is to proteins. Now listen carefully: edema, which is excess fluid outflow into the interstitium, is commonly caused by an increase in capillary hydrostatic pressure, or a rise in Pc, for example in heart failure. It can also happen due to increased capillary permeability, or increased Kf, as seen in cases of toxins, infections, or burns. And it may occur due to increased interstitial fluid oncotic pressure, or increased Pi-I, for example in lymphatic blockage. Lastly, it can result from decreased plasma proteins, or reduced Pi-C, as seen in nephrotic syndrome, liver failure, or protein malnutrition. You should remember this: osmotic pressure and hydrostatic pressure work together to influence fluid exchange. From the arteriole to the venule, fluid filters out into the interstitium during the first part, and then gets reabsorbed back into the capillary. That means filtration results in a net flow out of the capillary, and reabsorption results in a net flow back into it. So, to summarize, net fluid flow equals Kf times the difference between capillary hydrostatic pressure and interstitial hydrostatic pressure, minus the reflection coefficient times the difference between plasma oncotic pressure and interstitial fluid oncotic pressure. Now let's talk about cardiovascular pathology, beginning with congenital heart diseases, which include right-to-left shunts, often presenting as early cyanosis, also known as blue babies. These conditions are usually diagnosed prenatally or become evident immediately after birth, and they usually require urgent surgical treatment and, sometimes, the maintenance of a patent ductus arteriosus, or PDA, using prostaglandin therapy. You should remember the 5 T's: truncus arteriosus, that's one vessel; transposition, which involves 2 switched vessels; tricuspid atresia, remember 3 stands for tetralogy of Fallot, for meaning tetra; and finally, TAPVR, which has 5 letters in its name. Now listen carefully: in persistent truncus arteriosus, the truncus arteriosus fails to divide into the pulmonary trunk and the aorta, and this happens due to failure of the aorticopulmonary septum formation. Most patients who have this condition also have an accompanying ventricular septal defect, or VSD. In detransposition of the great arteries, the aorta leaves the right ventricle, which is anterior, and the pulmonary trunk leaves the left ventricle, which is posterior, causing separation of the systemic and pulmonary circulations. This condition is not compatible with life unless a shunt, like a VSD, PDA, or patent foramen ovale, is present to allow mixing of blood. It occurs due to failure of the aorticopulmonary septum to spiral, and on chest X-ray, it may show a narrow superior mediastinum, causing the classic egg on a string appearance. Without surgical intervention, most infants with this condition die within the first few months of life. Are you following me? Good, because next is tricuspid atresia, which is the absence of the tricuspid valve, leading to a hypoplastic right ventricle. This defect requires both an atrial septal defect, or ASD, and a ventricular septal defect or PDA to be viable. On ECG, you might see hypertrophy of the right atrium, showing tall P waves, and of the left ventricle, showing left axis deviation. Now let's talk about tetralogy of Fallot, which is caused by anterosuperior displacement of the infundibular septum, and is the most common cause of early childhood cyanosis. The four features include pulmonary infundibular stenosis, which is the most important determinant for prognosis, right ventricular hypertrophy, showing a boot-shaped heart on chest X-ray, an overriding aorta that straddles the VSD and receives blood from both ventricles, and finally, the ventricular septal defect. Pulmonary stenosis forces right-to-left flow across the VSD, leading to RVH and TET spells, which are often caused by crying, fever, or exercise due to worsening right ventricular outflow obstruction. You should remember the mnemonic prove. Interestingly, squatting increases systemic vascular resistance, decreases the right-to-left shunt, and improves cyanosis. Tetralogy of Fallot is associated with 22q11 syndromes. Now listen carefully. In total anomalous pulmonary venous return, the pulmonary veins drain into the right heart circulation, such as the superior vena cava or the coronary sinus. This condition is associated with an atrial septal defect and sometimes a PDA, which allows for right-to-left shunting to maintain cardiac output. Moving on to abstain anomaly, this condition involves the displacement of tricuspid valve leaflets downward into the right ventricle, which causes the ventricle to become partly atrialized. It is associated with tricuspid regurgitation, accessory conduction pathways, and right-sided heart failure. It is a rare condition and can be caused by lithium exposure in utero. Now let's shift to left-to-right shunts, which are acyanotic at presentation, but cyanosis may occur years later. In terms of frequency, ventricular septal defect, or VSD, is the most common, followed by atrial septal defect, or ASD, and then patent ductus arteriosus, or PDA. Remember this, right-to-left shunts cause early cyanosis, while left-to-right shunts cause later cyanosis. In a ventricular septal defect, the baby may be asymptomatic at birth, and the defect may manifest weeks later or remain asymptomatic for life. Most smaller defects resolve spontaneously, but larger ones, if left untreated, lead to increased pulmonary blood flow and left ventricular overload, resulting in Eisenmenger syndrome and possibly heart failure. You should remember that oxygen saturation increases in the right ventricle and pulmonary artery. In an atrial septal defect, which is a defect in the interatrial septum, there's typically a systolic ejection murmur with a wide, fixed split of the second heart sound. Ostium secundum defects are the most common and are usually isolated, while ostium primum defects are less common and often occur with other anomalies. This is different from a patent foramen ovale, which is due to failed fusion, not a missing septum. Oxygen saturation increases in the right atrium, right ventricle, and pulmonary artery. ASD may lead to paradoxical emboli, where systemic venous emboli bypass the lungs and become systemic arterial emboli, especially during temporary shunt reversal, such as when lifting weights or in Eisenmenger syndrome. It is also associated with Down syndrome. Now let's talk about patent ductus arteriosus, which in the fetal period allows a right-to-left shunt, and that's normal. But in the neonatal period, as pulmonary vascular resistance decreases, the shunt becomes left to right, which can cause progressive right or left ventricular hypertrophy and heart failure. It's associated with a continuous, machine-like murmur. Patency is maintained by prostaglandin E synthesis and low oxygen tension. If left uncorrected, PDA can result in late cyanosis in the lower extremities, which is called differential cyanosis. Remember, the ductus arteriosus is normal in utero and usually closes soon after birth. Now listen carefully. Eisenmenger syndrome is caused by an uncorrected left-to-right shunt, whether VSD, ASD, or PDA, which leads to increased pulmonary blood flow, followed by pathologic remodeling of the vasculature, leading to pulmonary arterial hypertension. The right ventricle hypertrophies to compensate, and when the pressure in the RV exceeds that in the LV, the shunt reverses direction and becomes right to left. This causes late cyanosis, digital clubbing, and polycythemia. The age of onset varies, depending on the size and severity of the initial left-to-right shunt. Next, let's discuss coarctation of the aorta, which is an aortic narrowing near the insertion of the ductus arteriosus, often called juxtaductal. It's associated with bicuspid aortic valve, other congenital heart defects, and Turner syndrome. You might see hypertension in the upper extremities and cyanosis, claudication, coolness, and weak or delayed pulses. This is called brachiofemoral delay, in the lower extremities. With age, intercostal arteries enlarge due to collateral circulation, which causes rib notching on X-ray. Complications can include heart failure, increased risk of cerebral hemorrhage, like Berry aneurysms, aortic rupture, and infective endocarditis. Now let's wrap up with persistent pulmonary hypertension of the newborn, where pulmonary vascular resistance remains elevated after birth. This is associated with abnormal development and adaptation of the pulmonary vasculature, and risk factors include aspiration of meconium-stained amniotic fluid and neonatal pneumonia. The high pulmonary pressure leads to a right-to-left shunt through the foramen ovale and the ductus arteriosus. In this case, oxygen saturation before the ductus, or preductal, is often higher than after it, or postductal. The newborn will present with signs of respiratory distress like tachypnea and may show differential cyanosis, but without delay in pulses. You should remember this chart of congenital cardiac defect associations. Prenatal alcohol exposure, such as in fetal alcohol syndrome, is linked with VSD, PDA, ASD, and tetralogy of Fallot. Congenital rubella is associated with PDA, pulmonary artery stenosis, and septal defects. Down syndrome is linked to AVSD, VSD, and ASD. Infants of diabetic mothers may develop transposition of the great arteries, truncus arteriosus, tricuspid atresia, or VSD. Marfan syndrome is associated with mitral valve prolapse, thoracic aortic aneurysm or dissection, and aortic regurgitation. Prenatal lithium exposure is linked with abstain anomaly. Turner syndrome is associated with bicuspid aortic valve, aortic coarctation, and dissection. Williams syndrome is known for supravalvular aortic stenosis. And finally, 22q11 syndromes are linked with truncus arteriosus and tetralogy of Fallot. Hypertension is defined as persistent systolic blood pressure greater than or equal to 130 mm of mercury, or diastolic blood pressure greater than or equal to 80 mm of mercury. Now listen carefully. Risk factors include increasing age, obesity, diabetes, physical inactivity, a high-sodium diet, excess alcohol intake, tobacco smoking, and family history, while incidence is greatest in black populations, followed by white, then Asian individuals. About 90% of hypertension cases are primary, also called essential hypertension, and are related to increased cardiac output or increased total peripheral resistance. The remaining 10% are mostly secondary to renal or renovascular diseases, such as fibromuscular dysplasia, which shows a characteristic string of beads appearance of the renal artery, usually seen in adult females, or atherosclerotic renal artery stenosis, primary hyperaldosteronism, or obstructive sleep apnea. Are you following me? Hypertensive urgency means severe hypertension, defined as blood pressure at or above 180/120, without acute end organ damage, but hypertensive emergency includes the same pressure range along with evidence of acute damage, such as encephalopathy, stroke, retinal hemorrhages and exudates, papilledema, myocardial infarction, heart failure, aortic dissection, kidney injury, microangiopathic hemolytic anemia, or eclampsia. In this condition, arterioles may show fibrinoid necrosis. Hypertension. If chronic and untreated, the condition predisposes to coronary artery disease, concentric left ventricular hypertrophy mediated by angiotensin II and endothelin, heart failure, atrial fibrillation, aortic dissection or aneurysm, stroke, chronic kidney disease known as hypertensive nephropathy, and retinopathy. Now let's talk about hyperlipidemia signs. Xanthomas are plaques or nodules composed of lipid-laden histiocytes in the skin, especially on the eyelids, and these are called xanthelasma. Tendinous xanthoma refers to lipid deposits in tendons, especially the Achilles tendon and finger extensors, and is associated with familial hypercholesterolemia. Corneal arcus is the deposition of lipid in the cornea, commonly seen in older adults and referred to as arcus senilis, but when seen earlier in life, it suggests hypercholesterolemia. You should remember this. Atherosclerosis is a very common form of arteriosclerosis, which refers to the hardening of arteries. This disease affects elastic arteries, and large and medium-sized muscular arteries, and is caused by the buildup of cholesterol plaques in the tunica intima. The common locations affected include the abdominal aorta, followed by the coronary artery, then the popliteal artery, carotid artery, and finally the circle of Willis. Let that order stick with you. There's even a mnemonic, a copycat named Willis. The risk factors are divided into modifiable and non-modifiable. Modifiable risk factors include hypertension, tobacco smoking, dyslipidemia characterized by increased LDL and decreased HDL, and diabetes. Non-modifiable ones include age, male sex, postmenopausal status, and family history. Symptoms might be angina or claudication, but sometimes there are no symptoms at all. The progression of this disease involves inflammation and is key to its pathogenesis. It begins with endothelial cell dysfunction, leading to macrophage and LDL accumulation, followed by foam cell formation and fatty streaks. Then smooth muscle cells migrate, a process involving PDGF and FGF, and these cells proliferate and deposit extracellular matrix. This results in fibrous plaque and ultimately complex atheromas. These can calcify, and the calcium content actually correlates with the risk of complications. Now listen carefully. Complications include ischemia, infarction, aneurysm formation, peripheral vascular disease, thrombosis, embolism, renovascular hypertension, coarctation of the aorta, and subclavian steal syndrome. Now, let's talk about cholesterol emboli syndrome. This refers to microembolization of cholesterol that is displaced from atherosclerotic plaques in large arteries, usually the aorta. It results in end organ damage due to small artery emboli and triggers an inflammatory response. Clinical signs include livedo reticularis, digital ischemia also called blue toe syndrome, acute renal failure, cerebrovascular accident, and gut ischemia. Despite these symptoms, pulses remain palpable because the larger arteries are not affected. This condition may follow invasive vascular procedures such as angiography, angioplasty, or endovascular grafting. You should also remember arteriolosclerosis, which is another common form of arteriosclerosis that affects small arteries and arterioles. There are two types. First, the hyaline type, which involves vessel wall thickening secondary to plasma protein leakage into the subendothelium, often seen in hypertension or diabetes mellitus. Second, the hyperplastic type, which features onion skinning in severe hypertension, due to smooth muscle cell proliferation. Now let's talk about aortic aneurysm, which is a localized pathologic dilation of the aorta. It may cause abdominal or back pain, and this can be a sign of leaking, dissection, or even imminent rupture. When we focus on thoracic aortic aneurysm, it is associated with cystic medial degeneration. Risk factors include hypertension, bicuspid aortic valve, and connective tissue diseases like Marfan syndrome. It's also associated with tertiary syphilis, which causes obliterative endarteritis of the vasa vasorum. Dilatation at the aortic root may lead to aortic valve regurgitation. Now, moving down to the abdominal aortic aneurysm, it is associated with transmural inflammation involving all three layers of the vessel wall, along with extracellular matrix degradation. Risk factors include tobacco smoking, which is the strongest one, as well as increasing age, male sex, and family history. Clinically, it may present as a palpable, pulsatile abdominal mass. In the case of rupture, it presents as a classic triad: a pulsatile abdominal mass, acute abdominal or back pain, and resistant hypotension. These aneurysms are most often infrarenal because that region has reduced distribution of the vasa vasorum. Traumatic aortic rupture is due to trauma or deceleration injury such as motor vehicle accidents or a significant fall, and it most commonly occurs at the aortic isthmus, which is the proximal descending aorta, just distal to the origin of the left subclavian artery. A chest X-ray may reveal a widened mediastinum, and now let's talk about another critical condition. Aortic dissection, marked by a longitudinal intimal tear forming a false lumen, is associated with hypertension, which is the strongest risk factor, and may also relate to a bicuspid aortic valve, or inherited connective tissue disorders like Marfan syndrome. This can present with tearing and sudden onset chest pain that radiates to the back, possibly with markedly unequal blood pressure in the arms. A chest X-ray can show mediastinal widening. It can result in organ ischemia, embolic stroke, aortic rupture, or even death. Now listen carefully. Stanford type A dissection, also known as proximal dissection, involves the ascending aorta, may extend to the aortic arch or descending aorta, and could result in acute aortic regurgitation or cardiac tamponade. Treatment here is surgery. On the other hand, Stanford type B dissection, which is distal, involves only the descending aorta, below the left subclavian artery, and the treatment includes beta blockers first, followed by vasodilators. Next, subclavian steal syndrome involves stenosis of the subclavian artery, proximal to the origin of the vertebral artery, leading to hypoperfusion distal to the stenosis, and a reversed blood flow in the ipsilateral vertebral artery, which results in reduced cerebral perfusion during exertion of the affected arm. It causes arm ischemia, pain, paresthesia, and vertebrobasilar insufficiency, which includes dizziness and vertigo. A greater than 15 mm of mercury difference in systolic blood pressure between the arms may be observed. This syndrome is associated with atherosclerosis, which is the most common cause, but can also be due to Takayasu arteritis or heart surgery. Now let's talk about coronary artery disease, starting with angina, which is chest pain due to ischemic myocardium secondary to coronary artery narrowing or spasm, and without necrosis. There are several types. First, stable angina, usually secondary to atherosclerosis with at least 70% occlusion, presents with exertional chest pain in a classic distribution that resolves with rest or nitroglycerin. Then, unstable angina, which involves thrombosis with incomplete coronary artery occlusion, leads to an increase in frequency or intensity of exertional chest pain, or any chest pain at rest, but with no cardiac biomarker elevation, unlike non-ST segment elevation MI. Are you following me? Let's continue with vasospastic angina, formerly known as Prinzmetal or variant angina, which occurs at rest and is due to coronary artery spasm, showing transient ischemic ST changes on ECG. Tobacco smoking is a major risk factor, and triggers include cocaine, amphetamines, alcohol, and triptans. It is treated with calcium channel blockers, nitrates, and smoking cessation, if applicable. Now, myocardial infarction is most often due to an acute coronary syndrome, involving rupture of a coronary artery atherosclerotic plaque, which leads to acute thrombosis. However, it can also occur with a prolonged supply-demand mismatch, like stable angina followed by prolonged tachycardia and hypotension from pneumonia, causing elevated troponin levels but no acute plaque rupture. Here is a comparison. In stable angina, pain occurs on exertion, and troponin is not elevated. In unstable angina, pain happens with mild exertion or at rest, and again, troponin is not elevated. In STEMI, pain is at rest, and troponin is elevated with subendocardial infarction. In STEMI, pain is also at rest, troponin is elevated, and it involves transmural infarction with ST elevation and pathologic Q waves on ECG. Let's keep going, now with coronary steal syndrome. Distal to a coronary stenosis, vessels are already maximally dilated to compensate for reduced flow. When vasodilators like dipyridamole, adenosine, or regadenosin are administered, they dilate normal vessels, increase hydrostatic pressure in those areas, and blood is shunted toward well-perfused regions, reducing flow to the myocardium served by stenosed vessels. This phenomenon causes ischemia in that region. Vasodilator stress tests use this flow difference to detect potential ischemia, though rarely, they can induce coronary steal and actual ischemia. Vasodilation of healthy vessels steals blood from stenosed vessels. Now listen carefully. Sudden cardiac death refers to unexpected death due to cardiac causes within 1 hour of symptom onset, or within 24 hours if there were no previous cardiovascular symptoms. It is most commonly due to a lethal ventricular arrhythmia like ventricular fibrillation, which impairs blood flow to the brain. It is associated with coronary artery disease in up to 70% of cases, cardiomyopathies, myocarditis, coronary anomalies, and hereditary channelopathies like long QT syndrome or Brugada syndrome. Prevention includes using an implantable cardioverter defibrillator. Are you ready for more? Let's continue with chronic ischemic heart disease, which involves progressive exertional symptoms and/or heart failure due to chronic ischemic damage to the myocardium. In this condition, myocardial hibernation refers to left ventricular systolic dysfunction from chronic ischemia that may be reversible with reperfusion. It's seen in stable angina, acute myocardial infarction, or heart failure. In contrast, myocardial stunning is a transient and reversible LV systolic dysfunction after a brief ischemic episode. Finally, the evolution of myocardial infarction begins with the most commonly occluded arteries, the left anterior descending, followed by the right coronary artery, and then the circumflex. Symptoms include diaphoresis, nausea, vomiting, severe retrosternal pain, pain radiating to the left arm or jaw, shortness of breath, and fatigue. From 0 to 24 hours, you may see dark mottling or pale areas with tetrazolium stain on gross examination, and microscopically, there are wavy fibers early in 0 to 4 hours, then in 4 to 24 hours you will see by early coagulative necrosis, and release of cell contents. Reperfusion injury can cause free radical generation, increased calcium influx, and hypercontraction of myofibrils, which appear as dark eosinophilic stripes. Complications include ventricular arrhythmia, heart failure, or cardiogenic shock. From 1 to 3 days, in gross examination of heart there is hyperemia, and, in microscope view there is extensive coagulative necrosis. The surrounding tissue shows acute inflammation with neutrophils. This stage is associated with post-infarction fibrinous pericarditis. Between 3 and 14 days, grossly there is a hyperemic border and central yellow-brown softening appear, and on microscope we see macrophages start removing dead tissue, followed by granulation tissue formation at the margins. Complications in this period include free wall rupture leading to tamponade, papillary muscle rupture leading to mitral regurgitation, or interventricular septal rupture causing a left-to-right shunt. Left ventricular pseudoaneurysm also becomes a risk. And from 2 weeks to several months, a gray-white contracted scar is seen by naked eye. Complications now include post-cardiac injury syndrome, ongoing heart failure, arrhythmias, and the formation of a true ventricular aneurysm, which carries a risk for mural thrombus. Now listen carefully. The diagnosis of myocardial infarction begins with the understanding that, in the first 6 hours, an ECG is the gold standard. Cardiac troponin I rises after 4 hours, peaks at 24 hours, and remains elevated for 7 to 10 days. It is more specific than other protein markers. In contrast, CKMB increases after 6 to 12 hours, peaks between 16 and 24 hours, and while it is predominantly found in the myocardium, it can also be released from skeletal muscle. That's why it's useful in diagnosing reinfarction following an acute MI, because its levels return to normal after about 48 hours. ECG changes can include ST elevation, which is seen in STEMI and indicates a transmural infarct, or ST depression, which is associated with STEMI and indicates a subendocardial infarct. You should also watch for hyperacute, or peak T waves, as well as T wave inversion, and either pathologic Q waves or poor R wave progression, which can suggest an evolving or old transmural infarct. Now let's talk about the pattern of biomarker changes over time. On a timeline from 1 to 8 days after myocardial infarction onset, you'll see that troponin 1 levels can rise as high as 50 times the upper limit of normal, peaking early and staying elevated for days, while CKMB rises more modestly, returning to baseline by around day 2. These curves are essential when interpreting lab results in both initial infarction and suspected reinfarction. Now are you ready to dive into the ECG localization of STEMI? Let's go through it carefully. The leads with ST segment elevations or Q waves correspond to specific infarct locations. When the anteroseptal region is involved, which is supplied by the LAD, the ST elevations appear in leads V1 to V2. For an anteroapical infarct, typically involving the distal LAD, look at V3 to V4. Anterolateral, LAD or LCX, will be shown in V5, V6. Now listen carefully, if you see changes in leads 1 and AVL, that indicates a lateral infarct, which corresponds to the left circumflex artery, or LCX. And for an inferior infarct, which is supplied by the right coronary artery, the significant leads are 2, 3, and AVF. Posterior infarct due to occluded PDA, will be shown in V7 to V9 or ST depression in V1 to V5 with taller waves. Now let's talk about narrow complex tachycardias. A narrow QRS complex is defined as less than 120 milliseconds, and it indicates rapid ventricular activation via the normal ventricular conduction system. This means the tachycardia originates within or above the AV node, making it a supraventricular arrhythmia. For example, in atrial fibrillation, the rate and rhythm are irregularly irregular, with no discrete P waves. The arrhythmogenic activity usually originates from automatic foci near the pulmonary vein ostia in the left atrium. Common risk factors include hypertension, coronary artery disease, advanced age, and atrial dilation. This condition may predispose to thromboembolic events due to left atrial blood stasis, particularly stroke, and the most common site of thrombus formation in atrial fibrillation is the left atrial appendage. Management involves rate and rhythm control using beta blockers, calcium channel blockers, and digoxin, remember the acronym ABCD, and it can also involve cardioversion. On ECG, you'll see an irregular baseline with absent P waves, and RR intervals that are not equal, such as RR1 not equal to RR2, RR3, or RR4. Now listen carefully, multifocal atrial tachycardia also presents with an irregularly irregular rate and rhythm, but the key finding is at least 3 distinct P-wave morphologies. This is due to multiple ectopic foci in the atria, and it's often associated with underlying conditions such as COPD, pneumonia, and heart failure. On the other hand, atrial flutter is characterized by a rapid succession of identical, consecutive atrial depolarization waves, producing a sawtooth appearance of P waves on ECG. The arrhythmogenic activity usually originates from a re-entry circuit around the tricuspid annulus. Management is similar to atrial fibrillation, and catheter ablation of the region between the tricuspid annulus and the inferior vena cava may be considered. On ECG, you may see a regular rhythm like RR1 equal to RR2 and RR3, along with a classic 4 to 1 sawtooth pattern. Are you following me? Let's continue with paroxysmal supraventricular tachycardia, which is most often due to a reentrant tract between the atrium and ventricle, most commonly located in the AV node. This type often presents suddenly, with symptoms like palpitations, lightheadedness, and diaphoresis. Termination is achieved by slowing AV nodal conduction, using vagal maneuvers or adenosine, and definitive treatment is catheter ablation. Then we have Wolff-Parkinson-White syndrome, which is the most common type of ventricular pre-excitation syndrome. It involves an abnormal fast accessory conduction pathway from the atria to the ventricles, known as the bundle of Kent, which bypasses the rate-slowing AV node. As a result, the ventricles partially depolarize earlier, producing a characteristic delta wave, a widened QRS complex, and a shortened PR interval. This may result in a re-entry circuit, leading to supraventricular tachycardia. Treatment options include procainamide and ibutylide, while AV nodal, blocking drugs such as adenosine, calcium channel blockers, and beta blockers should be avoided. Remember, in orthodromic AV reentrant tachycardia, there is a retrograde P wave, while antidromic AV reentrant tachycardia is classified under wide complex tachycardias. Now let's shift to wide complex tachycardias, where the QRS complex is greater than or equal to 120 milliseconds. This indicates slow ventricular activation outside the normal conduction system, meaning the tachycardia originates below the AV node, classifying it as a ventricular arrhythmia. Ventricular tachycardia typically has a regular rhythm, with a rate greater than 100, and it is most commonly due to structural heart disease such as cardiomyopathy or myocardial infarction scarring. It carries a high risk of sudden cardiac death. Torsades de pointes is a type of polymorphic ventricular tachycardia, characterized by shifting sinusoidal waveforms. It may progress to ventricular fibrillation. A long QT interval predisposes to torsades, and causes include sinus bradycardia, congenital long QT syndromes, and electrolyte abnormalities like low potassium, magnesium, or calcium. Treatment includes defibrillation for unstable patients, and magnesium sulfate for stable ones. Now listen carefully. Drug-induced long QT syndrome is remembered by the acronym ABCDEF+NO, which stands for antiarrhythmics of class I, A and III, arsenic, antibiotics like macrolides and fluoroquinolones, antipsychotics such as haloperidol and chloroquine, antidepressants including tricyclics and diuretics like thiazides, antiemetics like ondansetron, antifungals like fluconazole, Naver-class protease inhibitors, and opioids like methadone. Ventricular fibrillation, on the other hand, is a disorganized rhythm with no identifiable waves, and it is fatal without immediate CPR and defibrillation. Then we have hereditary channelopathies, caused by inherited mutations of cardiac ion channels that lead to abnormal myocardial action potentials, increasing the risk for ventricular tachyarrhythmias and sudden cardiac death. Brugada syndrome is one such condition, autosomal dominant, and most commonly due to a loss-of-function mutation of sodium channels. It is more prevalent in Asian males, and the ECG pattern shows a pseudorite bundle branch block and ST segment elevations in leads V1 to V2. Prevention of sudden cardiac death involves implantable cardioverter defibrillators. Another condition is congenital long QT syndrome, most commonly due to loss-of-function mutations in potassium channels, which affect repolarization. The two types are Romano-Ward syndrome, which is autosomal dominant and presents with a pure cardiac phenotype without deafness, and Jervell and Lang-Nielsen syndrome, which is autosomal recessive and includes sensorineural deafness. Now let's talk about sick sinus syndrome, which is due to age-related degeneration of the SA node. On ECG, you might see bradycardia, sinus pauses indicated by delayed P waves, sinus arrests which show dropped P waves, and junctional escape beats. Moving on to conduction blocks, in first-degree AV block, there is a prolonged PR interval greater than 200 milliseconds, and no treatment is required as it is benign and asymptomatic. The PR intervals appear equal, such as PR1 equal to PR2, PR3, and PR4. Next, second-degree AV block Mobitz type I, or Wenckebach, shows progressive lengthening of the PR interval until a beat is dropped, meaning a P wave is not followed by a QRS complex. The RR interval varies with a regularly irregular pattern, and treatment is usually unnecessary. PR1 is less than PR2, which is less than PR3, followed by a P wave with an absent QRS. In contrast, second-degree AV block Mobitz type II features dropped beats that are not preceded by changes in PR interval. This may progress to third-degree block and usually reflects structural abnormalities such as ischemia or fibrosis, requiring a pacemaker. The PR intervals are constant, such as PR1 equal to PR2, followed by a P wave without a QRS. Now listen carefully. In third-degree, or complete AV block, the P waves and QRS complexes are rhythmically dissociated, meaning the atria and ventricles beat independently. The atrial rate is greater than the ventricular rate, and it may be caused by Lyme disease. Treatment involves a pacemaker. You may see P waves superimposed on QRS or T waves, and consistent intervals like PP1 equal to PP2 and RR1 equal to RR2. Let's wrap up with bundle branch blocks, where conduction is interrupted in the normal left or right bundle branches. The affected ventricle depolarizes slowly, cell to cell, while the unaffected side uses the fast His-Purkinje system. This condition is commonly due to degenerative changes like cardiomyopathy or infiltrative disease, and you can see characteristic patterns in leads like V1 and V6 in left bundle branch block. And finally, we come to premature beats. A premature atrial contraction arises from ectopic foci in the atria rather than the SA node. It is often due to increased adrenergic stimulation, such as from caffeine. While benign, it may increase the risk for atrial fibrillation and flutter. The ECG shows a narrow QRS complex with a preceding P wave. On the other hand, a premature ventricular contraction arises from the ventricle and not the SA node. It shortens diastolic filling time and reduces stroke volume compared to a normal beat. Prognosis depends largely on underlying heart disease, and the ECG will show a wide QRS complex without a preceding P wave. Now let's talk about the complications that can follow a myocardial infarction. First, we have cardiac arrhythmias, which may occur from the first few days to even several months after the infarction. These arrhythmias can be supraventricular, ventricular, or involve conduction blocks. The reason behind them is the death and scarring of myocardial tissue. You should remember this, because arrhythmias are a major cause of death both before a patient reaches the hospital and within the first 48 hours after the infarction. Are you following me? Good, because next comes peri-infarction pericarditis, which typically occurs 1 to 3 days after the infarction. It presents with pleuritic chest pain, a pericardial friction rub, ECG changes, and sometimes a small pericardial effusion. This condition is usually self-limited, meaning it tends to resolve on its own. Now listen carefully, because things get more critical. Around 2 to 7 days after the infarction, papillary muscle rupture can occur. This can lead to acute mitral regurgitation, cardiogenic shock, and severe pulmonary edema. The posteromedial papillary muscle is more commonly affected than the anterolateral one, because the posteromedial has only a single artery supplying it, the posterior descending artery, while the anterolateral muscle is supplied by both the left anterior descending artery and the left circumflex artery. Now let's talk about interventricular septal rupture, which happens between 3 to 5 days after the infarction. Symptoms may be mild or severe, with cardiogenic shock and pulmonary edema. The rupture is caused by macrophage-mediated degradation, which leads to a ventricular septal defect, increased oxygen saturation, and increased pressure in the right ventricle. Moving forward, you should remember ventricular pseudoaneurysm, which can appear between 3 to 14 days. It may not show symptoms, but if it does, they can include chest pain, a murmur, arrhythmia, syncope, heart failure, or an embolus from a mural thrombus. If it ruptures, it causes cardiac tamponade. This is actually a free wall rupture that is contained by adherent pericardium or scar tissue. It does not include endocardium or myocardium, and it is more likely to rupture than a true aneurysm. Now listen carefully, between 5 to 14 days, the patient may experience a ventricular free wall rupture, which leads to cardiac tamponade or internal hemorrhage, and this is often fatal. Interestingly, patients with left ventricular hypertrophy or a previous myocardial infarction are somewhat protected against this kind of rupture. Now let's talk about something that may occur later, true ventricular aneurysm, which shows up from about 2 weeks to several months after the infarction. It presents with symptoms similar to a pseudoaneurysm, but with an outward bulge during contraction, known as dyskinesia. This condition is associated with fibrosis. Finally, you should remember post-cardiac injury syndrome, also known as Dressler syndrome, which can occur weeks to several months later. This is a type of pericarditis that arises from an autoimmune reaction. After the heart is injured, cardiac antigens are released, which triggers the deposition of immune complexes in the pericardium, and that leads to inflammation. Now let's talk about acute coronary syndrome treatments. For unstable angina or STEMI, the approach includes anticoagulation, such as heparin, and antiplatelet therapy, like aspirin, along with ADP receptor inhibitors, for example clopidogrel. Beta blockers, ACE inhibitors, and statins are also used. Symptom control is achieved with nitroglycerin, and sometimes morphine may be added. But when we deal with STEMI, in addition to everything just mentioned, reperfusion therapy becomes the most important step. In this case, percutaneous coronary intervention is preferred over fibrinolysis. Now listen carefully. If the right ventricle is affected, such as in right coronary artery occlusion, it's crucial to support venous return and preload to maintain cardiac output. This is done by giving intravenous fluids and avoiding nitroglycerin, which could otherwise reduce preload and worsen the situation. Are you following me? Now let's talk about cardiomyopathies, beginning with dilated cardiomyopathy. This is the most common type, accounting for 90% of cases. It's often idiopathic or familial, and one example is a mutation in the TTN gene, which encodes the sarcomeric protein titin. Other causes include drugs like alcohol, cocaine, and doxorubicin, infections such as Coxsackie B virus and Chagas disease, ischemia from coronary artery disease, and systemic conditions like hemochromatosis, sarcoidosis, thyrotoxicosis, and wet beriberi. It can also occur as peripartum cardiomyopathy. Now listen carefully. Findings include heart failure, an S3 heart sound, a systolic regurgitant murmur, a dilated heart seen on echocardiogram, and a balloon appearance of the heart on chest X-ray. Treatment involves sodium restriction, ACE inhibitors or ARBs, beta blockers, sacubitril, diuretics, and mineralocorticoid receptor blockers such as spironolactone. In some cases, an implantable cardioverter defibrillator or even heart transplant may be necessary. Systolic dysfunction develops, and the heart displays eccentric hypertrophy, meaning sarcomeres are added in series. You should remember this is different from an athlete's heart, where enlargement of both the left and right ventricles helps increase stroke volume and cardiac output. There's also a condition called stress cardiomyopathy, also known as Takotsubo cardiomyopathy or broken heart syndrome, which shows ventricular apical ballooning likely due to increased sympathetic stimulation during emotionally stressful situations. Now let's move on to hypertrophic cardiomyopathy, which is different in several ways. Around 60 to 70% of cases are familial and inherited in an autosomal dominant pattern. The most common mutations are in genes encoding sarcomeric proteins, such as myosin-binding protein C and beta-myosin heavy chain. This condition can cause syncope during exercise and, tragically, may lead to sudden death in young athletes due to ventricular arrhythmias. The findings include an S4 heart sound and a systolic murmur. Mitral regurgitation may also occur due to impaired mitral valve closure. Treatment involves the use of beta blockers or non-dihydropyridine calcium channel blockers like verapamil, and in some cases, patients must stop participating in high-intensity sports. An ICD is indicated if the patient is considered high risk. Now listen carefully. Drugs that reduce preload, such as diuretics or vasodilators, should be avoided. In this type of cardiomyopathy, diastolic dysfunction develops, and the ventricles show concentric hypertrophy, where sarcomeres are added in parallel. This often affects the septum more than other areas. Myofibrillar disarray and fibrosis are seen histologically. When the left ventricular outflow tract is obstructed, the condition is classified as hypertrophic obstructive cardiomyopathy. In this form, asymmetric septal hypertrophy and systolic anterior motion of the mitral valve cause outflow obstruction, which in turn leads to dyspnea and possibly syncope. Now let's finish with restrictive or infiltrative cardiomyopathy. This form can be caused by post-radiation fibrosis, Loeffler endocarditis, endocardial fibroelastosis, which is thick fibroelastic tissue in the endocardium of young children, amyloidosis, sarcoidosis, and hemochromatosis. You can remember these causes with the phrase, "Please help." Diastolic dysfunction develops in this condition, and what's interesting is that you might see a low-voltage ECG despite the presence of a thick myocardium, especially in amyloidosis. Loeffler endocarditis is specifically associated with hypereosinophilic syndrome, and histology shows eosinophilic infiltrates in the myocardium. Now let's talk about heart failure, which is a clinical syndrome of cardiac pump dysfunction that leads to congestion and low perfusion. Symptoms include dyspnea, orthopnea, and fatigue, while signs include an S3 heart sound, RALS, jugular venous distension, or JVD, and pitting edema. Systolic dysfunction is known as heart failure with reduced ejection fraction, or HFrEF, where end-diastolic volume increases and contractility decreases, often secondary to ischemia, myocardial infarction, or dilated cardiomyopathy. Diastolic dysfunction, on the other hand, is called heart failure with preserved ejection fraction, or HFpF, which results from decreased compliance and increased end-diastolic pressure, often secondary to myocardial hypertrophy. Right heart failure most often results from left heart failure, but cor pulmonale refers specifically to isolated right heart failure due to a pulmonary cause. Are you following me? Now listen carefully to the treatments, because ACE inhibitors, ARBs, angiotensin receptor, neprilysin inhibitors, beta blockers, except during acute decompensated heart failure, and aldosterone receptor antagonists all reduce mortality in HFrEF. Loop and thiazide diuretics are used mainly for symptomatic relief, while hydralazine with nitrate therapy and SGLT2 inhibitors improve both symptoms and mortality in selected patients. Now let's focus on left heart failure symptoms. One is orthopnea, or shortness of breath when supine, occurs because of increased venous return from redistribution of blood, which is an immediate gravity effect that exacerbates pulmonary vascular congestion. Then there is paroxysmal nocturnal dyspnea, or breathless awakening from sleep, also results from increased venous return due to redistribution of blood and reabsorption of peripheral edema. Pulmonary edema occurs as pulmonary venous pressure increases, which leads to venous distension and transudation of fluid, and you may even find hemosiderin-laden macrophages, also called heart failure cells, in the lungs. Now moving on to right heart failure, where congestive hepatomegaly occurs due to increased central venous pressure, which raises resistance to portal flow, and rarely, this can lead to cardiac cirrhosis. This is associated with a nutmeg liver appearance on gross examination. Jugular venous distension happens because of increased venous pressure, and peripheral edema follows for the same reason, increased venous pressure leading to fluid transudation. Are you ready for the next concept? Let's talk about high-output heart failure, which is an uncommon form of heart failure characterized by increased cardiac output. The high-output state results from reduced systemic vascular resistance due to either vasodilation or arteriovenous shunting. Causes include severe obesity, advanced cirrhosis, severe anemia, hyperthyroidism, wet beriberi, and Paget disease of bone. It presents with symptoms and signs of both pulmonary and systemic venous congestion. Now listen carefully as we discuss shock, which is the inadequate perfusion and delivery of nutrients necessary for normal tissue and cellular function. Initially, it may be reversible, but it's life-threatening if not treated promptly. Different types of shock have different causes and mechanisms. Hypovolemic shock results from hemorrhage, dehydration, or burns and involves volume depletion, leading to cold, clammy skin, decreased central venous pressure, decreased pulmonary capillary wedge pressure, decreased cardiac output, increased systemic vascular resistance, and reduced mixed venous oxygen saturation. Cardiogenic shock, seen in myocardial infarction, heart failure, valvular dysfunction, or arrhythmia, involves left heart dysfunction with increased CVP and PCWP, reduced CO, and increased SVR, and reduced SVO2. Obstructive shock, due to pulmonary embolism or tension pneumothorax, involves impeded cardiopulmonary blood flow and shows similar patterns, increased CVP, reduced PCWP and CO, increased SVR, and reduced SVO2. Cardiac tamponade, a specific form of obstructive shock, also causes increased CVP, reduced PCWP, CO, and SVO2, and increased SVR. Distributive shock, seen in early sepsis or anaphylaxis, involves systemic vasodilation with warm, dry skin, reduced CVP and SVR, increased CO, and increased SVO2. In cases of CNS injury, all parameters drop or stay normal, but systemic vascular resistance can remain normal or increase. Now let's explore cardiac tamponade. This is compression of the heart by fluid, such as blood or effusions, which reduces cardiac output and causes equilibration of diastolic pressures in all four chambers. Findings include Beck triad, hypotension, distended neck veins, and distant heart sounds, along with increased heart rate and pulsus paradoxus. The ECG may show low-voltage QRS complexes and possibly electrical alternans due to the swinging motion of the heart in a large effusion. An echocardiogram shows pericardial effusion, systolic right atrial collapse, diastolic right ventricular collapse, and inferior vena cava plethora. Treatment involves pericardiocentesis or surgical drainage. You should remember this. Pulsus paradoxus is a drop in amplitude of systolic blood pressure by more than 10 mm of mercury during inspiration. Increased venous return during inspiration increases right ventricular filling, which shifts the interventricular septum toward the left ventricle due to reduced pericardial compliance, thus reducing left ventricular ejection volume and causing a drop in systolic blood pressure. This is seen in constrictive pericarditis, obstructive pulmonary diseases like croup, OSA, asthma, COPD, and of course, cardiac tamponade. Just remember the mnemonic, P-coat. Now let's move on to syncope, which is the transient loss of consciousness caused by reduced cerebral blood flow. There are different types. Reflex syncope is the most common and includes vasovagal, which has prodromal symptoms like warmth, pallor, and nausea, with short episodes and rapid recovery. Situational syncope can be triggered by coughing, sneezing, swallowing, defecation, or urination. Carotid sinus hypersensitivity, such as from wearing a tight collar, can also cause reflex syncope. Orthostatic syncope arises from hypovolemia, drugs like antihypertensives, or autonomic dysfunction. Orthostatic hypotension is defined as a drop in systolic BP by 20 mm of mercury or more, or a drop in diastolic BP by 10 mm of mercury or more within 3 minutes of standing. Cardiac syncope can result from arrhythmias or structural heart problems, such as aortic stenosis or hypertrophic cardiomyopathy. Now listen carefully, because we're about to dive into infective endocarditis, which is an infection of the endocardial surface of the heart, usually involving one or more heart valves, and it's caused by bacteria much more commonly than fungi. It comes in two forms. Acute endocarditis is classically caused by Staphylococcus aureus, which is highly virulent and forms large, destructive vegetations on previously normal valves with rapid onset. Subacute endocarditis is usually due to viridans streptococci, which are low virulence and form smaller vegetations on congenitally abnormal or diseased valves, often after dental procedures, and has a gradual onset. Patients typically present with fever, the most common symptom, and a new murmur, along with vascular and immunologic phenomena. Vascular findings include septic embolism, petechiae, splinter hemorrhages, and Janeway lesions, which are painless, flat, erythematous lesions on the palms or soles. Immunologic findings include immune complex deposition, glomerulonephritis, osseous nodes, which are painful, raised, violaceous lesions on the finger or toe pads, and Roth spots, which are retinal hemorrhagic lesions with pale centers. In infective endocarditis, the mitral valve is most commonly involved, followed by the aortic valve. Tricuspid valve involvement is strongly associated with injection drug use. Remember, don't try drugs. Are you following? Here are some key associations. Prosthetic valves are associated with Staphylococcus epidermidis, GI or GU procedures are linked to Enterococcus, colon cancer can point to Streptococcus galolyticus, and Hayseck organisms, Haemophilus, Aggregatibacter, Cardiobacterium, Eikenella, and Kingella, are gram-negative causes. Culture-negative endocarditis is often due to Coxiella or Bartonella. For injection drug users, common culprits include S. aureus, Pseudomonas, and Candida. The pathogenesis involves endothelial injury that leads to the formation of vegetations made of platelets, fibrin, and microbes on heart valves, which can result in valve regurgitation and septic embolism, systemic in left-sided endocarditis, and pulmonary in right-sided cases. Diagnosis requires multiple blood cultures and echocardiography. Now let's begin with deep venous thrombosis. A blood clot within a deep vein can lead to swelling, redness, warmth, and pain. This condition is often triggered by the Virchow triad, which you can remember with the acronym SHE. That stands for stasis, such as in the postoperative period or after a long drive or flight, hypercoagulability, like when there's a defect in coagulation cascade proteins such as factor V Leiden, or when a patient uses oral contraceptives or is pregnant, and endothelial damage, which occurs when exposed collagen activates the clotting cascade. When the DVT occurs in the proximal deep veins of the lower extremity, particularly the iliac, femoral, or popliteal veins, it can become a source of embolism. Clinically, a D-dimer test may be used to rule out DVT when the probability of disease is low or moderate. It's highly sensitive, but not very specific. However, the imaging test of choice is compression ultrasound with Doppler. For both prophylaxis and acute management, you should use unfractionated heparin or low molecular weight heparins, like enoxaparin. And for long-term prevention or treatment, direct anticoagulants such as rivaroxaban or apixaban are the preferred options. Now listen carefully as we transition to cardiovascular pharmacology, specifically the treatment of hypertension. For primary, also known as essential hypertension, the main treatments include thiazide diuretics, ACE inhibitors, angiotensin II receptor blockers, or ARBs, and calcium channel blockers. But when hypertension coexists with heart failure, you'll need to use ACE inhibitors or ARBs, beta blockers for compensated heart failure, aldosterone antagonists which offer a mortality benefit, and diuretics that improve symptoms and reduce hospitalizations. However, beta blockers must be used cautiously in decompensated heart failure and are contraindicated entirely in cardiogenic shock. Are you following me? Good. Now let's talk about hypertension with diabetes mellitus. In this case, ACE inhibitors or ARBs, calcium channel blockers, thiazide diuretics, and beta blockers are commonly used. ACE inhibitors and ARBs offer kidney protection against diabetic nephropathy, while beta blockers, though effective, can mask the symptoms of hypoglycemia. If your patient has asthma, then you'll want to use ARBs, calcium channel blockers, thiazide diuretics, or cardioselective beta blockers. But be careful, non-selective beta blockers must be avoided to prevent bronchoconstriction via beta-2 receptor stimulation, and ACE inhibitors should also be avoided to reduce confusion between drug-induced and asthma-related cough. Are you ready for the next one? In hypertensive patients who are pregnant, the safe and preferred medications are hydralazine, methyldopa, labetalol, and nifedipine. Just remember the phrase, hypertensive moms love nifedipine. When treating hypertension in patients with gout, ACE inhibitors, calcium channel blockers, and ARBs, especially losartan, are appropriate, but you should avoid loop and thiazide diuretics since they may provoke gout flares. In contrast, for patients who also have osteoporosis, thiazides are preferred as monotherapy and may be combined with ACE inhibitors or ARBs if needed, because thiazides increase calcium reabsorption, which helps with bone health. And finally, in patients with hypertension and pheochromocytoma, the appropriate treatment begins with alpha blockade using phentolamine or phenoxybenzamine before initiating beta blockade. This order is crucial because starting with beta blockers can lead to an unopposed alpha-mediated hypertensive crisis. Now let's talk about nitrates, specifically, nitroglycerin, isosorbide dinitrate, and isosorbide mononitrate. The mechanism here involves vasodilation by increasing nitric oxide in vascular smooth muscle, which leads to an increase in cGMP and results in smooth muscle relaxation. These drugs primarily dilate veins much more than arteries, and as a result, they reduce preload. Their clinical use includes angina, acute coronary syndrome, and pulmonary edema. But you should also know the adverse effects, which include reflex tachycardia. This can be treated with beta blockers, along with methemoglobinemia, hypotension, flushing, and headache. There's also a phenomenon known as Monday disease, which occurs in industrial nitrate exposure. In this situation, there's a development of tolerance to the vasodilating action during the work week and then a loss of tolerance over the weekend, which leads to tachycardia, dizziness, and headache upon re-exposure. These drugs are contraindicated in right ventricular infarction, hypertrophic cardiomyopathy, and with concurrent PDE5 inhibitor use. Now let's move on to calcium channel blockers. These include amlodipine, clofidipine, nicardipine, nifedipine, and nimodipine, which are dihydropyridines that act primarily on vascular smooth muscle, and also diltiazem and verapamil, which are non-dihydropyridines and act mainly on the heart. The mechanism involves blocking voltage-dependent L-type calcium channels of both cardiac and smooth muscle, resulting in reduced muscle contractility. In terms of vascular smooth muscle selectivity, amlodipine equals nifedipine, which is greater than diltiazem, which in turn is greater than verapamil. On the other hand, for cardiac tissue, verapamil is stronger than diltiazem, which is stronger than amlodipine or nifedipine. Dihydropyridines, except for nimodipine, are used to treat hypertension, angina, including the vasospastic type, and Raynaud phenomenon, with dihydropyridines mainly dilating arteries. Nimodipine is used specifically for subarachnoid hemorrhage to prevent delayed ischemia. Nicardipine and clofidipine are used in hypertensive urgency or emergency. Non-dihydropyridines are used for hypertension, angina, and rate control in atrial fibrillation or flutter, as well as for the prevention of nodal arrhythmias. Adverse effects include gingival hyperplasia. For dihydropyridines, the effects include peripheral edema, flushing, and dizziness. For non-dihydropyridines, you may see cardiac depression, atrioventricular block, hyperprolactinemia particularly with verapamil, and constipation. Now listen carefully as we talk about hydralazine. Its mechanism is to increase cGMP, which promotes smooth muscle relaxation, and it vasodilates arterioles more than veins, leading to afterload reduction. Clinically, it's used for severe hypertension, particularly in acute cases, and for heart failure when combined with an organic nitrate. It is also safe to use during pregnancy. It is frequently co-administered with a beta blocker to prevent reflex tachycardia. Adverse effects include compensatory tachycardia, so it's contraindicated in angina or coronary artery disease, as well as fluid retention, headache, angina, and drug-induced lupus. Now let's talk about hypertensive emergencies. These are treated with labetalol, clofidipine, phenoldipam, nicardipine, and nitroprusside. Nitroprusside is a short-acting vasodilator that works on both arteries and veins and increases cGMP through the direct release of nitric oxide. However, it can cause cyanide toxicity, because it releases cyanide. Phenoldipam is a dopamine D1 receptor agonist that causes vasodilation in the coronary, peripheral, renal, and splanchnic vessels. It lowers blood pressure and increases natriuresis. It is also used postoperatively as an antihypertensive. But it can cause hypotension, tachycardia, flushing, headache, and nausea. Let's look at antianginal therapy. The goal here is to reduce myocardial oxygen consumption, abbreviated as MVO2, by reducing one or more of its determinants, end diastolic volume, blood pressure, heart rate, and contractility. If we compare nitrates, beta blockers, and the combination of both, here's what we find. For end diastolic volume, nitrates reduce it, beta blockers have no effect or may increase it, and the combination results in no effect or a reduction. For blood pressure, both nitrates and beta blockers reduce it, and so does the combination. Regarding contractility, nitrates may increase it as a reflex response, beta blockers reduce it, and the combination has little or no effect. As for heart rate, nitrates increase it reflexively, beta blockers reduce it, and the combination has no effect or may reduce it. Ejection time is reduced by nitrates, increased by beta blockers, and relatively unchanged with the combination. Overall, MVO2 is reduced by nitrates, reduced by beta blockers, and even more significantly reduced when both are used together. And remember, non-dihydropyridine calcium channel blockers like verapamil and diltiazem are similar to beta blockers in effect. Now listen carefully as we explore ranolazine. Its mechanism involves inhibiting the late phase of the inward sodium current, and this action helps reduce diastolic wall tension and oxygen consumption. Importantly, it does not affect heart rate or blood pressure. Its clinical use is in cases of refractory angina, and the adverse effects include constipation, dizziness, headache, nausea, and QT prolongation. Let's now talk about sacubitril. This drug is a neprilysin inhibitor, and it works by preventing the degradation of bradykinin, natriuretic peptides, angiotensin II, and substance P, which leads to increased vasodilation and a reduction in extracellular fluid volume. It is used in combination with valsartan, which is an angiotensin receptor blocker, to treat heart failure with reduced ejection fraction, or HFrEF. Adverse effects include hypotension and hyperkalemia, which is due to the ARB component of the therapy, along with cough, dizziness, and an important contraindication: it should not be used with ACE inhibitors because both drugs increase bradykinin levels and this can lead to angioedema. Now let's dive deeper into vascular tone and how it relates to aldosterone secretion. With a neprilysin inhibitor like sacubitril, several normally active peptides are converted into inactive products. These include natriuretic peptides and angiotensin II. Meanwhile, angiotensin receptor blockers like valsartan work directly on angiotensin II receptors. Are you ready to switch gears? Let's now turn to lipid-lowering agents. Here's how they affect lipids, LDL, HDL, and triglycerides, while also considering their mechanisms and adverse effects. Statins, such as atorvastatin, levastatin, pravastatin, rosuvastatin, and simvastatin, greatly reduce LDL, increase HDL, and reduce triglycerides. Their mechanism is to inhibit HMG-CoA reductase, which decreases cholesterol synthesis in the liver. This leads to a reduction in intrahepatic cholesterol, promotes recycling of LDL receptors, and increases LDL catabolism. Most importantly, statins reduce mortality in patients with coronary artery disease. Adverse effects include hepatotoxicity, which is marked by elevated liver function tests, and myopathy, especially when statins are used in combination with fibrates or niacin. Now let's talk about bile acid resins like cholestyramine, cholesevelam, and cholestyramine. These also reduce LDL, while slightly increasing HDL and triglycerides. They work by disrupting the enterohepatic circulation of bile acids, which causes a compensatory increase in the conversion of cholesterol into bile. This lowers intrahepatic cholesterol levels and increases LDL receptor recycling. However, side effects include gastrointestinal upset and reduced absorption of other drugs as well as fat-soluble vitamins. Let's look at ezetimibe. It reduces LDL, has little to no effect on HDL, and has little to no effect on triglycerides. Its mechanism is to prevent cholesterol absorption at the brush border of the small intestine. Though generally well tolerated, it may rarely cause increased liver function tests and diarrhea. Listen carefully as we go through fibrates. The two main agents are fenofibrate and gemfibrozil. These drugs reduce LDL, increase HDL, and strongly reduce triglycerides. They work by activating PPAR-alpha, which then upregulates lipoprotein lipase, increasing triglyceride clearance. In addition, they activate PPAR-alpha to induce HDL synthesis. However, the adverse effects you should remember include myopathy, especially when used with statins, and cholesterol gallstones, which occur via inhibition of cholesterol 7-alpha hydroxylase. Are you following me? Let's now discuss niacin. It reduces LDL, increases HDL significantly, and reduces triglycerides as well. Its mechanism involves the inhibition of lipolysis, which is mediated by hormone-sensitive lipase, in adipose tissue. This leads to reduced hepatic production of VLDL. Some notable side effects include a flushed face, which is prostaglandin-mediated and can be reduced by NSAIDs or long-term use, and other effects such as hyperglycemia and hyperuricemia. Now let's talk about PCSK9 inhibitors, namely alirocumab and evolocumab. These drugs drastically reduce LDL, slightly increase HDL, and slightly reduce triglycerides. Their mechanism involves the inactivation of LDL receptor degradation, which results in increased removal of LDL from the bloodstream. Adverse effects include myalgias, and less commonly, neurocognitive symptoms such as delirium and dementia. Ready for more? Let's cover fish oil and marine omega-3 fatty acids. These slightly increase both LDL and HDL, while at high doses they reduce triglycerides. It's believed they work by reducing free fatty acid delivery to the liver, decreasing the activity of triglyceride synthesizing enzymes, reducing VLDL production, and inhibiting the synthesis of ApoB. The side effects include nausea and a fish-like taste. Now listen carefully as we break down the biochemical pathways involved. We start with HMG-CoA reductase, which converts acetyl-CoA into mevalonate, and ultimately into cholesterol. Cholesterol contributes to triacylglyceride, VLDL, and the HDL pool. Free fatty acids, also known as FFA, are acted upon by LPL or lipoprotein lipase, and are involved in cholesterol metabolism, bile acid production, and more. FFA originate from adipose tissue through lipolysis and enter pathways that also involve bile acid metabolism. Let's now focus on where the medications act. Statins, such as atorvastatin, levastatin, pravastatin, rosuvastatin, and simvastatin, work by inhibiting cholesterol synthesis. Ezetimibe blocks cholesterol absorption in the intestine. Fibrates, including fenofibrate and gemfibrozil, promote LPL upregulation. Niacin inhibits lipolysis in adipose tissue. Bile acid resins, such as cholestyramine, cholesevolin, and cholestyramine, block bile acid reabsorption. PCSK9 inhibitors like alirocumab and evolocumab prevent LDL receptor degradation. Now let's talk about digoxin. Its mechanism involves direct inhibition of the sodium-potassium ATPase, which then indirectly inhibits the sodium-calcium exchanger. This results in increased intracellular calcium, and that leads to positive inotropy. It also stimulates the vagus nerve, which helps reduce the heart rate. Imagine this sequence: more calcium inside the cell, increased binding to troponin C, and ultimately, stronger cardiac contractions. So, sodium-potassium ATPase is blocked, the sodium-calcium exchanger is affected, calcium builds up, and the sarcoplasmic reticulum releases even more calcium, which results in increased cardiac contraction. Now, in terms of clinical use, digoxin is given for heart failure because it increases contractility, and it's also used in atrial fibrillation, as it reduces conduction at the AV node and depresses the SA node. But be careful, because adverse effects can include cholinergic symptoms like nausea, vomiting, diarrhea, and a peculiar blurry yellow vision often called van glow. It can also cause arrhythmias, particularly atrial tachycardia with AV block. A very important sign of poor prognosis is hyperkalemia caused by digoxin toxicity. Now listen closely, there are several factors that predispose a patient to digoxin toxicity. These include renal failure, which reduces excretion, hypokalemia, which enhances digoxin binding at the potassium site on the sodium-potassium ATPase, and drugs that either displace digoxin from its tissue-binding sites or reduce its clearance. Examples of such drugs include verapamil, amiodarone, and quinidine. And now, for the antidote: if there is digoxin toxicity, slowly normalize potassium levels, consider using a cardiac pacer, give antidigoxin Fab fragments, and administer magnesium. Now let's shift to antiarrhythmics, specifically the sodium channel blockers, known as Class I agents. These drugs slow or block conduction, especially in depolarized cells. They reduce the slope of phase 0 depolarization and show increased action at faster heart rates. This state-dependent effect means that the faster the heart rate, the less time sodium channels spend in the resting state, which reduces the time drugs have to dissociate from their receptor. Among these, Class 1C shows the strongest effect, followed by 2A, and then 3B. So, just remember, fast taxi CAB, 1C is strongest, then 1A, then 1B. Now get ready for Class 1A agents, which include quinidine, procainamide, and disopyramide. A helpful mnemonic is, the Queen proclaims Disso's pyramid. These drugs cause moderate sodium channel blockade, and they increase action potential duration, increase effective refractory period and ventricular action potentials, and also increase the QT interval. They also have some potassium channel blocking effects. Clinically, Class 1A agents are used in both atrial and ventricular arrhythmias, especially for reentrant and ectopic supraventricular tachycardias and ventricular tachycardias. However, their adverse effects include synchronism, which presents as headache and tinnitus with quinidine, reversible lupus-like syndrome with procainamide, heart failure with disopyramide, thrombocytopenia, and torsades de pointes due to the prolonged QT interval. Now let's talk about Class 1B agents, which are lidocaine and mexiletine. A good mnemonic here is, I by Liddy's Mexican Tacos. These drugs cause weak sodium channel blockade and reduce action potential duration. They preferentially affect ischemic or depolarized Purkinje and ventricular tissue. Clinically, Class 1B agents are best used for acute ventricular arrhythmias, especially those that occur post-myocardial infarction, and they're also used in digitalis-induced arrhythmias. Just remember, IB is best post-MI. The adverse effects include central nervous system stimulation or depression, and cardiovascular depression. Now let's move on to Class 1C antiarrhythmics. These include flecainide and propafenone. A helpful mnemonic to remember is, can I have fries, please? These drugs exert a strong sodium channel blockade and they significantly prolong the effective refractory period in the AV node and in accessory bypass tracts. However, they have no effect on the effective refractory period in Purkinje and ventricular tissue, and they cause minimal changes in action potential duration. When it comes to clinical use, Class 1C agents are used for supraventricular tachycardias, including atrial fibrillation. But, they're only used as a last resort in cases of refractory ventricular tachycardia. Now, you should remember this, these drugs are proarrhythmic, especially after myocardial infarction, so they are contraindicated in patients with structural or ischemic heart disease. Just remember, 1C is contraindicated in structural and ischemic heart disease. Now let's talk about Class 2 antiarrhythmics, also known as beta blockers. Examples include metoprolol, propranolol, esmolol, atenolol, timolol, and carvedilol. These drugs decrease SA and AV nodal activity by reducing cyclic AMP and reducing calcium currents. They suppress abnormal pacemakers by decreasing the slope of phase 4 depolarization, and they especially affect the AV node, leading to an increased PR interval. Among these, esmolol is very short-acting. Now listen carefully. Clinically, beta blockers are used for supraventricular tachycardia, for controlling the ventricular rate in atrial fibrillation and atrial flutter, and for preventing ventricular arrhythmias after a myocardial infarction. But like all drugs, they have their adverse effects. These include impotence, exacerbation of chronic obstructive pulmonary disease and asthma, cardiovascular effects like bradycardia, AV block, and heart failure, and also central nervous system effects such as sedation and sleep disturbances. Beta blockers can also mask the signs of hypoglycemia. You should remember this, metoprolol can cause dyslipidemia, while propranolol can worsen vasospasm in patients with vasospastic angina. Also, beta blockers, with the exception of the non-selective alpha and beta antagonists like carvedilol and labetalol, can cause unopposed alpha-1 agonism if given alone in cases of pheochromocytoma or cocaine toxicity, although this concern is not well substantiated. If a beta blocker overdose occurs, treat it with glucagon, atropine, and saline. Remember the mnemonic gas. Now, just picture the pacemaker cell action potential. The beta blockers decrease the slope of phase 4 depolarization and prolong repolarization at the AV node, shifting the threshold potential and modifying the rhythm over time. Now let's talk about Class 3 antiarrhythmics, also known as potassium channel blockers. The key drugs to remember are amiodarone, ibutylide, dofetilide, and sotalol, and a simple mnemonic is AIDS. These medications work by increasing the action potential duration, increasing the effective refractory period, and prolonging the QT interval. Clinically, they are used for atrial fibrillation and atrial flutter, and also for ventricular tachycardia, especially amiodarone and sotalol. But you should remember this, each drug has its own adverse effects. Sotalol can cause torsades de pointes and excessive beta blockade, while ibutylide is also associated with torsades de pointes. Amiodarone is particularly notorious for multiple side effects. These include pulmonary fibrosis, hepatotoxicity, hypothyroidism or hyperthyroidism because amiodarone is 40% iodine by weight. It also acts as a hapten, causing corneal deposits and blue-gray skin deposits, which lead to photodermatitis. On top of that, it may cause neurologic effects, constipation, and cardiovascular issues like bradycardia, heart block, and heart failure. Now listen carefully, when using amiodarone, you must remember to check pulmonary function tests, liver function tests, and thyroid function tests. Amiodarone is lipophilic and has effects from class I, class II, class III, and class IV antiarrhythmic classes. It also markedly prolongs repolarization by blocking the delayed rectifier potassium current, known as IK. Now let's move on to class IV antiarrhythmics, which are calcium channel blockers. The main drugs here are diltiazem and verapamil. They work by decreasing conduction velocity, increasing the effective refractory period, and prolonging the PR interval. They slow the rise of the action potential and prolong repolarization specifically at the AV node. So, how are they used? Well, they are especially helpful for rate control in atrial fibrillation or flutter and for the prevention of nodal arrhythmias. But don't forget the adverse effects. These include constipation, gingival hyperplasia, flushing, edema, and cardiovascular effects such as heart failure, AV block, and sinus node depression. Now listen carefully, because we're not done yet. There are other antiarrhythmics to keep in mind. Adenosine increases potassium efflux out of cells, which hyperpolarizes the cell and reduces the calcium current, ultimately decreasing AV node conduction. It is the drug of choice in diagnosing and terminating certain forms of supraventricular tachycardia. And remember this, adenosine is very short-acting, lasting about 15 seconds. Its effects can be blunted by theophylline and caffeine because both are adenosine receptor antagonists. Adverse effects include flushing, hypotension, chest pain, a sense of impending doom, and bronchospasm. Magnesium is used and effective in torsades de pointes and digoxin toxicity. Now, are you ready for one last important drug? Let's talk about ivabradine. Its mechanism involves prolonging slow depolarization, specifically phase 4, by selectively inhibiting funny sodium channels, also known as IF. Clinically, it's used for chronic heart failure with reduced ejection fraction. But keep an eye out for its side effects, which include luminous phenomena or visual brightness, hypertension, and bradycardia.